Come on over.
Good morning. Kim Cece from Lifelong Medical. I'm the Deputy Chief Medical Officer there. Glad to be here.
And you want to introduce yourself? Okay. And I'll just say we'll call that the roll call since we've all introduced ourselves. The agenda has come out and it is, this is kind of a weird, I'm not used to this. So are we supposed to vote to approve the agenda, or am I just, because I saw in the minutes it said Supervisor Burgess approved the agenda and I'm not used to that. So
Some committees do, some committees I serve on do that, and it's just a matter if anyone wants to change the order of agenda. And so I used to say I'm good with the order of agenda, and unless either of you wishes to change it, we're good with the order of the agenda.
Great. One addition that I'd like to make to the agenda is just to advise everyone that we uploaded the agenda slide deck to Legistar beyond the 96-hour time limit. So we have a written proposal to the JCC to consider and approve that we uploaded those slide decks to Legistar.
Okay, well, I'm going to go ahead and move that we do waive the 96-hour time limit, except the addition of the presentation slide deck to the posted agenda. This does not materially change the agenda. The agenda was the same, but it's the slide deck which many of us rely upon as we go through the meeting.
and all in favor? Aye. Opposed? And we can do that since we're all in the room together.
Wonderful. Thank you very much.
Thank you. So we will now move on to approve December 13th, 2024 minutes. Does anybody have any changes or comments on that? No?
I will move to approve.
Okay, are there any public comments on that? If there's no public comments, I do have a motion and a second. And I just want to make sure, who's
Recording our
who's
votes.
recording our votes? I just want to make sure. Oh, okay, so you're good?
Okay.
Okay, I just want to make sure we're good. All in favor? Aye. Opposed? Did we already do that? Sorry. Okay.
No.
And it's unanimous. All right. We're moving on to item 1.4, public comments on any items under the jurisdiction of this committee and not on this agenda. Do we have any public comments?
And that could include online, since we do have online.
Do we have online? Okay.
Is someone monitoring the online?
Okay. Okay.
No hands raised.
Okay. So you'll need to say it out loud to me, okay? Because I can't see you. All right. So there are no public comments. Are there any comments from the JCC? I just want to thank Dr. Lowe for stepping in as the interim. You've been doing this for days and, well, 2 days. So you got it all under control. I want to thank you for stepping up. Thank you, Dr. Z-Ellie. I've got to say it right. I've got to say it right.
Pretend there's no.
And I was going to say, I appreciate the communication that has already been demonstrated the last couple days and weeks. So thank you. Those are my comments. We'll move on to item 2.0, responding to federal threats to the California public health care system.
Supervisor, before we move on to that,
Yes.
I did want to make sure we do additional housekeeping items, which are to confirm who the chair will be for this year and also to confirm all the appointments that we have for our JCC membership.
Okay, that was not agendized. So
Okay, we can bring that to our next JCC.
It's housekeeping. I mean, if it's housekeeping, we can put it under JCC comments.
okay.
I think
I defer to the JCC.
I'm fine having Diane remain as chair.
Okay.
So
Are you guys okay with that too? Hey, wait a minute. Are you all right with that? Okay, so that covers that.
Yes, thank you very much.
What else did you need?
That was it.
Okay. That was hard. All right. So now we can go on to item 2.0, responding to federal threats to California public health care system. And is that going to be Erica? And Erica, yeah. Very close to the microphone. Am I close enough? Okay, thank you.
Okay, how's
She
that?
said I'm great.
Great, okay. No one's ever accused me of being quiet, so. I'm Erica Murray. I'm the president and CEO of the California Association of Public Hospitals and Health Systems. It's a mouthful, but we just say CAPH. And I'm really pleased to be here today to give you an update. I can't give you a prediction, but I can give you an update on all the things that are happening at the federal level and how it might impact Contra Costa and other public healthcare systems. Let's see. I am a complete technological idiot.
You just have to go ahead and let me know to change slides, and I'll take care of that for
Okay,
you.
I'll just say change slide. Okay, next slide, please. Okay, so CAPH represents 17 public healthcare systems across California, primarily in the Bay Area, as you'll see, also in Los Angeles, out in the Stockton area. We also represent the 5 University of California health systems, 3 of whom were the county hospital back in the day and then were acquired by the University of California, and 2 of whom we represent because the financing for their Medi-Cal and uninsured services are the same as for county systems. So at a certain point, we all just said, well, we're all caring for the patients and paying for it the same way. So CAPH represents all 5 UC systems. I'll also just note that we purposefully say public healthcare systems, and I'm sure you folks in Contra Costa will appreciate this, because we're more than public hospitals. We, as you know, healthcare systems include primary and specialty care clinics, sometimes on the hospital campus, but also out in the community that may look a lot like a private community health center or an FQHC, but actually are a county health clinic. So we try to make sure that in our nomenclature that we're emphasizing the systemness of the services we provide. Next slide. What I'd like to do today, at least try, is to contextualize what you may be concerned about at the local level in terms of budgets or executive actions and how it might impact Contra Costa with the state and federal perspective. And then probably where I'm noticing I'll get most questions, so I'm going to spend most of my time is on the budget reconciliation process. And then I'd like to leave time for questions. I'll do my best to answer them. Next slide. So there are 4 major arenas of activity. And as I said, I'm going to focus the bulk of my remarks on budget reconciliation, but I did want to note that there are 4, one of which has concluded at least temporarily. There is Congress has the power of the purse, so it is charged with spending the money, and that is the appropriations process. And you may recall that several weeks ago, President Trump signed what's called a continuing resolution, which essentially says how we were spending the money, we're going to spend it the same way. And that they signed a continuing resolution through September 30th, which is the end of the federal fiscal year. For our purposes, we were worried about Medicaid dish cuts that were set to go into effect on April 1st, 2025. And those were put into the Affordable Care Act back in 2014 with the assumption that as coverage expanded, those providers who were receiving Medicaid dish would experience reductions in uncompensated care. And while that did happen, the reliance on those Medicaid dish dollars for various reasons did not diminish. And so ever since 2014, we have successfully lobbied Congress to either delay or outright eliminate those scheduled dish reductions, and we were able to do that here too. So the good news is the appropriations process is done and set aside for 6 months, and the dish cuts will not go into effect. And that allows us to turn our attention to the budget reconciliation process, which is different. There's the appropriations is spending the money, and the budget reconciliation process, I like to say, is sort of how much should we spend. So that's where we'll focus. Next slide. The number one question I get in some form or fashion, at least once a day, is how big will these Medicaid cuts be? I sure wish I knew the answer to that. What we do know is that the House, in their budget resolution, they instructed the Energy and Commerce Committee to find $880 billion of savings over 10 years. President Trump has said publicly that he wants to protect Medicare and Social Security. So when you look at what the Energy and Commerce Committee's jurisdiction is and where the possibilities are, you cannot find $880 billion without significant cuts to Medicaid. So the Senate now, this is a little bit outdated. I had to send the slides ahead of time, and every week this is updated. So the Senate had two options: take the House passed budget resolution and amend it, or start from scratch. They did something kind of in the middle. They took up a resolution that allows the House to do its own thing, and they're going to do their own thing, which is it's clever. It allows for threading the needle of giving the Senate the flexibility to approve lower cuts in Medicaid than the House might. But at some point, the two chambers are going to have to come together and figure out a reconciliation. So more than anything, it kicks the can down the road a bit in terms of these really difficult choices, and that raises a procedural question too of how are they going to reconcile what ultimately comes out of each chamber. As I said, there's this very narrow tightrope to walk here because you've got a very loud vocal contingent of moderates, especially in the House. And we'll talk about some of the representatives who we are especially focused on. You also have a very loud vocal contingent of fiscal conservatives, the Freedom Caucus, who believe the $880 billion did not go far enough. And ultimately, this process is going to have to figure out how to mollify both caucuses to pass something. And with such a narrow vote margin, although the special elections earlier this week in Florida help that vote margin, even still, the sizes of both of those caucuses are big enough to mean they're going to have to find some sort of compromise. Next slide. We can skip this one. This is last week, trying to stay current. In terms of timing, they're trying to get this done by Memorial Day. And I would say the conventional wisdom is good luck. With such a wide range of perspectives within the same party's caucus, it seems very challenging to come to a resolution on this in the next couple of months. And I think the Senate's actions in setting minimal cuts and largely letting the House do its own thing is an indication that they're not close to being able to find that middle ground yet. But that is certainly the goal. Next slide. I would characterize the conversations about these Medicaid cuts as a spaghetti strategy. When the Energy and Commerce Committee came up with its $880 billion figure, congressional leadership and committee leadership started throwing ideas on the wall to see what might stick. And that the conversation changes almost weekly in terms, so I get calls, well, what about this idea or what about that idea? So I'll share with you what is being flung to the wall right now, but I caution that it is not what's necessarily sticking, it's just what they're considering right now. So the first thing that they're asking questions about is something called a state-directed payment. A state-directed payment is in a category of Medicaid financing streams that we call supplemental. But a supplemental payment, it's really a misnomer because when you look at the base rates that public healthcare systems and any Medicaid provider receive, they don't come anywhere close to covering the actual costs of providing those services, the base rate, whether it's in fee-for-service or managed care. And so the provider needs to find supplemental payments to try to cover those costs. State-directed payments are one such mechanism to provide those supplemental payments. And if you may have heard of the Enhanced Payment Program or the EPP or the Quality Incentive Pool, the QIP, those are the two major state-directed payments that Contra Costa Health Services and other public healthcare systems rely on. They are widespread across the country. Big states like Texas and Florida use state-directed payments. They are not just permissible. CMS finalized a rule last spring that allow these state-directed payments actually to go up to what they call the average commercial rate. So there have been some accusations that state-directed payments are somehow fraudulent or wasteful. They are completely legitimate, very widespread financing mechanisms to help Medicaid providers cover their costs. But what is happening is in this spaghetti strategy conversation, some leaders are saying, well, we're not talking about cutting Medicaid. We're talking about reforming Medicaid or finding waste, fraud, and abuse. So the effort here is to explain each one of these and especially help folks understand how it's not wasteful. It's not fraudulent. They're completely permissible, legal, and common structures for financing the Medicaid system. Provider taxes are another such one of these supplemental payments. In California, there is a provider fee that's around $5 billion. It is primarily used to supplement Medicaid payments for private hospitals. Next slide. One policy that has been on the table recently is a proposal to lower it's called the FMAP, which is the FMAP just means the federal match, whereas Medicare is fully financed by the federal government. Medicaid is a federal state program. So we talk about the federal share and the non-federal share. The federal share is called the FMAP. And there's a proposal to lower the FMAP for states that cover the undocumented. This is intended to target California and New York. And this proposal, the biggest vulnerability here is actually procedural. The budget reconciliation process, in that process, you're not allowed to single out specific states. And so it bumps up against some parliamentarian rules in the Senate. And we believe that this is likely to be challenged in the Senate if it actually becomes part of what they consider. There's also a proposal to change the way the payments for the expansion population. When we say the expansion population, I'm referring to the growth in Medicaid or Medi-Cal in California from the Affordable Care Act. So in 2014, we expanded Medi-Cal to include not just those in particular aid codes, but anyone with a certain income or above. And this proposal suggests that instead of just making those payments for those expansion services, they would put what they call a per capita cap, basically a fixed dollar amount per enrollee, so that if enrollment went up, the dollars would go up, but the rate of growth for a per capita cap would remain below inflation, which is how they achieve savings. So again, it's explaining this to folks in a way that helps them understand that is a cut. It's sure you can call it a reform, but because it's not going to keep up with inflation, it achieves significant savings, especially in the out years. And that savings is what would be cut from providers like Contra Costa. I will say that one policy that does seem to have stuck to the wall are around work requirements, which is the idea that all folks on Medi-Cal, on Medicaid, should be demonstrating that they either are working or need to be looking for work. And the estimates are that instituting a work requirement would save about $100 billion a year. When people have looked at work requirements as a new requirement within their states, Arkansas and Georgia are currently implementing work requirements. What they generally find is that people do fall off the rolls, which is how you achieve $100 billion in savings, but it's because of paperwork errors. It's because you're adding another round of paperwork, and 9 times out of 10, it's like 9.8 times out of 10. The reason they're falling off the rolls is because their name didn't match the name they put on a different form. It's bureaucratic errors that ultimately get resolved. However, this seems to be resonating with congressional leadership, and I think we are all at least quietly conceding that this is likely to be part of whatever package is approved. They are also considering particular savings in various regulations that came out of the Biden administration, and it's hard to know exactly which ones, although the staffing ratios for nursing homes is likely going to be on the list. And then there's a wide array of other Medicaid-related regulations. The savings will really just depend on what they pick and choose out of those savings. And those are not big dollar amounts. I think they're really, when you have to get to 880, they're looking at everything. And then I just put this on here just as a note that there's also some discussion of seeking some savings out of the Prevention and Public Health Fund. Next slide. So again, those are the policies that are being considered now. There are other ones that have been considered several weeks ago that I didn't put on this list. It doesn't mean they won't come back around. They're really just trying to see what might gain some traction and credibility. But the good news is, of everything I just described, only one of them really has. So they're going to keep trying. What we need to do is explain how each one of these, even if it's complicated and it's hard to understand. I think sometimes when people think something's complicated, it's therefore shady somehow. And we have to say, this isn't shady. It's completely legitimate. Yes, it's complicated, but let's explain it to you and try to break it down and help them understand how important these funding sources are, what it means for patient access to care, and why what they're proposing to do, because they have dollar signs attached to them, it is a cut. We are targeting these conversations, especially in congressional districts that have high Medicaid populations. I'll call out specifically David Valadao, who has Kern Medical, a county hospital in his congressional district. David Valadao has been in Congress for 9 years, and in 2017 voted to repeal and replace the Affordable Care Act after getting a lot of pressure not to. And then he lost his seat, and he had to gain it back. So he has lived the realities of voting for or against Medicaid policies in a district where 62% of his residents are on Medicaid. So we're having these conversations with everybody in our congressional delegation, but particularly focused on these specific representatives, because these are the ones who have high Medi-Cal and who could align with the moderates and vote to oppose whatever Medicaid cuts might be in the final package. The third strategy we're employing is to align ourselves with our colleagues in Medicaid financing in large red states. The financing structures, many of which I just described, Texas also has them, Florida has them, Louisiana has them. So we are making new friends and recognizing that sometimes California may not be the most appropriate lead messenger. And effective advocacy means knowing who is the best and most appropriate entity to carry the message. Next slide. The other question I get, in addition to how big the cuts will be, is some version of, so what's going to happen? I don't know. It is very fluid, and I think it's very hard to predict. I think I experience certainly every day there's a new headline of something I wouldn't have predicted. So rather than trying to crystal ball this, I advise us to just lump the possibilities into 3 different categories. I think there is a chance that we experience a worst case scenario where essentially the Trump administration concludes that they have basically one bite at the apple, and they're going to try to do everything they can in one big piece of legislation, and they're going to roll the moderates and try to live to fight another day in 2026 in terms of the election. It's entirely possible. It's also possible that because the savings for all of these policies are over a 10-year period, we could see a package of Medicaid cuts that are bad, but don't happen tomorrow. They go into effect 4, maybe even 5 years from now, in which case we would live to fight another day. And nothing would happen immediately, and we would need to engage in significant advocacy to prevent those things from happening when they were set to take effect. Another possibility is somehow the array of policies that they ultimately decide to cut Medicaid don't impact us public healthcare systems directly. Now, any cut to Medi-Cal in California is going to have at least an indirect impact on county health systems. If private hospitals take a significant reduction in their provider fee, that's going to impact the services they provide and the patients they see, and which would have a ripple effect here. So I don't mean to diminish that. I'm just, for purposes of broad categorization, there are ways to think about, there's the really bad, and then there's the kind of bad. And then there's this whole thing, as evidenced by the Senate's actions this week, is a really tough needle to thread. And they're trying to accomplish a lot in a quick amount of time with a whole host of other things happening at the international level. It might just all fall apart. We will just have to see. Next slide. Can be a tough pill to swallow, though, is everything I just shared is only in the congressional realm. That's just what's happening vis-a-vis budget reconciliation. There's also all of the actions that are happening in HHS, the workforce reductions, the executive orders. I will call out one particular little noticed guidance that they released several weeks ago, where they rescinded their policy on what they call health-related social needs, which is the federal acronym for social determinants of health. So they basically said, we don't believe that broadening the scope of Medicaid to include things like social needs is an appropriate use of Medicaid funds. That has really big implications, maybe not right now, but when California goes to renew its CalAIM waiver at the end of 2026, the rescission of that policy sends a pretty strong signal that California will have a tough time getting that waiver renewed. So it's important for us to understand that is beneficial as CalAIM services are, they might be short-lived. It's also important to know, speaking of waivers, that our public healthcare systems have an existing 1115 waiver that expires at the end of 2026. And it features a program we call the Global Payment Program, or GPP. And it is an innovative program that's designed to target initially those who remained uninsured and then who became covered through state only, to create incentives for public healthcare systems to treat those patients not in the emergency or inpatient setting, but out in primary and specialty care wherever possible. It's been a very successful program, but because it is a California-specific program that targets the remaining uninsured, many of whom are undocumented, and it expires at the end of 2026, we believe it's extremely vulnerable and is not likely to be renewed. So it's important to, I'm contradicting myself, but when people say, what should we count on? I think it is prudent to count on the loss beginning in 2027 of those funds that are in the GPP, and I included those figures here. They also might rescind any of these policy regulations that came out in the past several years. And I think the most troubling action from my standpoint that the new administration under HHS has taken in the past several months is they just announced they would no longer receive public comment in the Federal Register, which means they have given themselves carte blanche to engage in rulemaking with no stakeholder input. So we have to monitor the Federal Register now every day to see what decisions they might decide, and they can make it effective immediately. Next slide. And that's all at the federal level. Exactly. This is just womp, womp, womp. At the state level, many of you probably saw that Governor Newsom recently sought to borrow $6.2 billion from the general fund to cover Medi-Cal costs. we are in this in-between period where the governor had released his January budget, and we're awaiting what they call the May revise, when they have a better sense of tax receipts and possible revenue. Usually we don't get this strong a signal of where the May revise might go prior to the May revise, but this borrowing is a clear indication that the Newsom administration believes the Medi-Cal program is too expensive, and so we're bracing ourselves for some Medi-Cal cuts. There is a widespread belief that might be targeting the state-only expansion of the undocumented. As a reminder, there are 4 categories of what we call the undocumented, but it's really those with unsatisfactory immigration status, or UIS. There are those who they're in that category because they are DACA or PRU-Call or otherwise here waiting for their status. Then you've got the kids. Governor Brown expanded coverage, Medi-Cal coverage for kids. Then there was the 26 to 49-year-olds. Actually, then there were the 50 and over. And then most recently, they expanded coverage to the 26 and 49. So I break all that out because those of us talking in the hallways in Sacramento are trying to predict whether they'll roll back all or some of that coverage and where they might get the biggest bang for their buck. We've heard publicly from the Senate Pro Tem that they do not want to roll back this coverage, which is encouraging. And it does seem like they're going to need to find some Medi-Cal cuts. So it's going to be bad. We just don't know how bad or where. And that makes it important for us to engage in advocacy. Dr. Walker was with me in Sacramento, meeting with our elected representatives and talking about the important work that you all do in caring for everybody, no matter what. And we'll need to be engaged in more specific policy conversations, both prior to May revise, but especially after May revise and before they have to sign a final budget in mid-January. And that might be it. Oh, no. Okay. 4 pieces of advice. So unsolicited, I will give you some advice on how to handle the barrage of information and all of this bad information. I would encourage us to respond to what we know, not what we're afraid might happen. It's very easy to go to doomsday worst case scenario and just decide that's definitely going to happen because it might alleviate some anxiety to just pick a scenario, but we don't know. It's also tempting to try to model out everything, if you just took every single one of those policy proposals that I listed and tried to say, okay, well, what would this mean for Contra Costa? Well, the only thing I can tell you for sure is that list is going to change next week. So you would end up spending a lot of time trying to predict something that is very, very fluid. So I would discourage you from doing that too. By the same token, I don't think it's prudent for any of us to think this is all going to be fine. It is not going to be fine. We know it's going to be bad. We can assume we're going to lose the GPP. We can assume we're going to have to institute work requirements. And then the question is what else and when? Next slide. It's important to stay current, but to try to do that without spinning, like I said. And the relentless advocacy, cannot say again how important it is to engage with your elected officials, help them know what we're worried about, why it matters, the impact to patients, the impact to the local economy, and wherever possible, have elected officials engage with one another. When we were in Sacramento, a lot of what we were asking, especially our Republican lawmakers, to do is pick up the phone and call their congresspeople and say, hey, just want to make sure you're fully aware of what this might mean at the local level. So with that, I'm happy to take questions. I'm sorry this was, I'm a bit of Debbie Downer, but I hope this was helpful in at least giving shape to what you may be reading in the news.
Well, I think it's following advice number 3, stay current, right?
Yes.
So I think, thank you very much. Do you have any questions or comments? No? Do you have any?
It's all speculative. Yeah.
It really is speculative.
So no, what I was going to say is I really appreciate this. Because this is happening in so many different realms that we as the Board of Supervisors have to deal with. I think your approach of being aware, but don't try to model out every possibility because it's going to be completely sideways of what you thought. It is just the reality, and then trying to create calm rather than fear in the public. And it's just interesting. I was in seeing my own primary care doctor yesterday for an annual physical. And she said, "What's going on?" She said, "All of my patients are coming in and saying, I'm going to lose coverage." And I said, well, who are your patients? She said, well, most of them are older, Medicare. And I said, they're the least likely to lose coverage, but just keep telling them, don't worry, because we don't know. And there's nothing we can do. And that's just sort of the reality.
Yeah, but I don't think it's also a bad idea to go in and get your doctor's appointments and get your
That's a
testing
bad idea.
done. And, I mean, even with, the tariff thing, there's kind of good strategies to kind of try to combat things. You said one thing about the Senate and the House doing their thing. You said it kind of kicks the can down the road, and I didn't know and then you started talking about timing, but what is that about the same timing that you're thinking?
It's not clear how the timing's going to play out. I know they want to move quickly, and so the Senate's giving its own committees instructions for lower cuts, but also allowing the House to proceed with its bigger cuts just means that at some point they're going to have to both pass the same bill.
Right.
And what the Senate didn't do is the Senate allowed for both possibilities. So they're delaying that ultimate reconciliation.
And so then so you got the House and then you got the Senate, and then how does the Energy and Commerce Committee play into those?
Very good question. The Energy and Commerce Committee is the committee in the House with the jurisdiction over Medicaid cuts. The Senate Finance Committee is the committee in the Senate with jurisdiction over Medicaid cuts. But in addition to that, they have other jurisdictions. So it's
Complicated.
It's messy. It's messy.
So then the other question about this work requirement, what percentage of Contra Costa uses our health plan? I think it's like 22% or 20, I don't. 27. I was trying not to exaggerate. I was going to say 24. So, but the thing is we only have a 4.8 unemployment rate, right?
Most people on Medi-Cal already work.
Right.
Or legitimately are unable to work.
Right.
So instituting this work requirement is simply, in my opinion, just an administrative burden that will likely fall at the local level. And it is designed to reduce enrollment through paperwork.
And there was an article recently, I don't know if I still have it up. Yeah, it was in The Guardian called "The Basis of Eugenics," Elon Musk and the menacing return of the R word. And there was just this kind of theory that this was an effort to put people who are disabled and elderly out. And I don't need you to comment on that because I think that would probably not be good for you to do that. But so what is the deal? If someone can't work, is there a way of, I'm trying to figure out what this whole thing is.
I think the rationale is they want evidence that they're unable to work,
Mhm.
and which the current Medi-Cal eligibility and enrollment process already includes. The intention here is to add another layer of proof, but the end result will be that many people will lose coverage because they forgot to check a particular box.
And so then that goes to, I have two more things. So I've been in Washington, D.C. twice.
Thank you.
Talking about this, and, we don't know what we don't know, and same with them. But the one thing that I've heard consistently, particularly when I was at the National Association of Counties, is that there's a lot of Republican rural communities that are extremely dependent on this and that this could really hurt them. So I don't know if that's,
Why the advocacy is so important by everybody, especially those supervisors and other elected officials in those rural communities, to make it clear this is going to have a horrible impact on folks' health and the economy.
and are we seeing that kind of groundswell occurring?
We are.
Okay.
And they're also feeling the pressure to pass legislation.
Right.
I think what may be a deciding factor here is at the end of the day, when they do try to, if they are able to try to thread the needle,
Uh-huh.
if President Trump weighs in, and if he lends his support to a final package, even if it has lower cuts, he's going to try to get the fiscal hawks to go along, or he might weigh in and say, sorry, moderates, I know this is going to hurt your local communities, especially in rural areas, but we need this to happen.
And then, you're talking about the FMAP and how California and New York are kind of being targeted, but there's states like Texas and Florida. What is their situation? Are they just not providing healthcare? And so then the burden's on these private hospitals to,
In essence, yes.
okay.
So they have not expanded Medicaid, so they have a much higher uninsured rate than California. And they also rely very heavily on the supplemental payments. Because their state government doesn't want to invest hardly at all in Medicaid, so they push the responsibility to the counties and to local healthcare districts. So yes, they're in some respects, although they haven't expanded coverage, we have a lot in common with them.
And so then are their health insurance rates higher there too?
That's a good question. I don't
I
know
would
that off the top
imagine,
of my head, but
Because someone has to pay for it.
right. I mean, you understand that we all pay for healthcare, regardless, one way or another, we pay for it.
Right.
And the question is, do we want to pay for folks getting regular primary preventive care, or do we want to wait for them to show up in the emergency room?
Because what costs less, right?
Exactly.
And the next presentation will kind of piggyback very nicely on this. Are there any questions from within the room? Identify yourself too. Yeah.
It takes effect, the state budget year is July 1st. They have to pass a budget by June 15th. They have these ways of passing fake budgets while they figure things out over the course of the summer. But we'll certainly know what's on the table by early mid-May. And then we will just advocate like crazy between May and mid-June and over the course of the summer if needed. Like I said, I think it's going to be a series of tough choices, but it's better to be at the table than on the table. That's how I like to think of it.
And just for in the room purposes, did that question?
No.
Okay.
Please, read.
Can you repeat the question? Because she's not microphoned.
Oh, sure. Dr. Levin asked about the timing of the, when will the state budget go into effect?
One more question, and we'll have more, but Dr. Oz recently don't laugh. Has he recently indicated kind of his ideas of going forward on all of this?
Dr. Oz hasn't weighed in on Medicaid specifically.
Okay.
It's a big question and one that we need to learn more about. And we certainly know where Secretary Kennedy's interest is.
Right.
And are trying to understand how HHS can achieve his policy objectives while cutting the workforce. He's saying, a lot of what he says about the importance of health and resonate, but you need a public health workforce to make all of that happen. And
Right.
so there is a disconnect between what is being said and what is actually happening in terms of the decimation of the workforce. We don't have many clues about what particularly a CMS, the Center for Medicare and Medicaid Services, that Dr. Oz will be running. We don't really have an indication of what an Oz CMS will look like. Not
Okay.
yet.
Are there more questions from the inside the room?
I will just offer, as things continue to evolve, and in speaking to number 3, if you'd like me to come back with an update, I'm happy to do that. I know
Great.
this is happening all quickly.
Are there any public comments online?
Yes, we have a question from Mariana Moore. She wants to know what the acronym DISH stands for.
Oh, sorry. We live in acronym land, and I often forget to spell them out. DISH stands for Disproportionate Share Hospital.
Thank you.
And on that, I was hoping that in the future, we can have an acronym page for
got it.
our meetings in the future, because I think particularly for me, I switch gears on all kinds of industries, issues. And so to be able to quickly keep up with the conversation, it's really nice. And for the public who also may not be as familiar with those things. So is that the last public comment? It looks like we got another. We don't have you on microphone.
We're going to unmute her.
Oh, okay.
Yes, thank you. Can you all hear me?
Hello.
Yes.
Welcome.
Hello. Thank you. This is Mariana Moore. I'm the Senior Director for the Ensuring Opportunity Campaign here in Contra Costa. I appreciate this discussion very much, and I want to thank you for the presentation and thank this committee for having 2 rich and robust conversations in a short period of time. And I would definitely agree that we need more of them and continued updates. I just appreciate the presenter for your expertise and your presence. I want to say, in terms of the community, this has been the top topic of conversation at many tables I've been in, many of which are not health specific. So people are very concerned about this. They're tracking this very carefully. They are afraid and they want to be in action around this. I think I appreciate the comments in the conversation so far today about the most vulnerable members of our community. We always want to center that it's folks that are elderly and disabled. I mean, there was a justice and aging presentation, I think, last week around this, and it is scary what is going to happen to our elders and to disabled folks. Don't realize that. Immigrants, of course, are also very vulnerable, very concerned, and it's so unfortunate that just as we're reaching, close to covering all the remaining uninsured, and now these rollbacks are being threatened, and we need to be in action together. And that's my final point. I think there's such a upswelling of action, advocacy, concern on the community side. There's many state and national organizations that local folks are connecting with. I heard someone say earlier that there's not a lot that we can do. There absolutely is things we can do. And I think this is like an all hands on deck moment. And I just want to let y'all know that the community is ready to be locked in arms with all of you in that room there and online to advocate together. And I really invite us to not do business as usual. Like, how do we creatively get those patient stories, go to Sacramento, call our folks for DC, really be in action, because this is like our house is on fire right now. Thank you.
Thank you, Mariana. Are there any other public comments?
No public comments.
All righty. Thank you so much for your
Appreciate it.
presentation.
Thanks, everybody.
Our next presentation is something I've been working on. And I actually don't know how, I think you guys are going to take this. Okay, good. So this is a presentation on a proposed healthcare literacy council. I'm in my 9th year on the Board of Supervisors. Fortunately or unfortunately, I've been a consumer of healthcare over the years. I've been personally, and then I've, as a mom, had to manage. And I recognize the need to be your own advocate. But as a county supervisor, as someone that sits on this committee and looks at other things, I recognize that there's a whole system that we can do better. One of them is making sure that people are getting the best health care they can get. And that means empowering them and giving them the information that they need to take good care of themselves and their families. The other part of it is we have hospitals, ambulance services, emergency rooms, and those systems are getting weighed down because of the people not really knowing what they should do. And then on top of that, we have a whole workforce that is really having to deal with a lot of different things when we could be more efficient. And so I have talked to numerous hospitals and just keep bringing it up. And Kaiser recently, last year, reached out to us and said, "Hey, we want to step it up." So we've met probably half a dozen times, and we have a plan, and it includes Contra Costa Health. And so we brought it here, and I'm going to turn it over. Please introduce yourselves, and you have the, yeah.
Great. Good morning, everybody. I'm Mike Miller with Brown Miller Communications. I'm here with Deneen Walford from Kaiser Permanente. And thank you. You pretty much have introduced the key points of this. I mean, there seems to be a real need, and we've been exploring this to understand what the needs are in terms of healthcare literacy. We've heard about health literacy, but healthcare literacy, we believe, is a real issue that we need to try and address. Can we go to the next slide? And you can go to the next slide.
See if I can.
Oh, does that work? Just pointed up. Okay. Great. We can go to the next slide. So again, as I mentioned, what we're looking at is helping Contra Costans successfully access and use their health care. And we want to make sure that they do this in an informed and efficient way. The needs for this are pretty clear. We can go to the next slide. We have a silver tsunami. So we're seeing the largest population ever moving on to Medicaid, Medicare roles that we have to try and address. We know with CalAIM, it's increasing the Medi-Cal eligibility for low income. So we've got a larger population there as well. Both of these are populations that may not have a real strong understanding of how to use healthcare. In East County, we're seeing a peak in enrollment in the East County. And it's one of the reasons that it's so nice to be working with Supervisor Burgess on this, because we really wanted to get our hands around what a healthcare literacy council might look like. And in the East County, we think that this is where a real priority is. And then what's clear, and this has been something that I think has plagued both the healthcare systems, whether it's Kaiser Permanente or whether it's Contra Costa Health, is that there's just limited knowledge of healthcare and how to use healthcare appropriately. Next slide. The outcome of this, the consequences we face are that seniors and low income are struggling to maximize the benefits. We've heard this again through both systems. There's the flip side of that is real anxiety, frustration, and anger by patients who come in who are trying to get care but don't know how to access that care appropriately, feel like it's taking too long, like they're getting the runaround, and it's often just them not understanding how to best use the system. One of the things that I think certainly is the biggest issue, one of the financial issues, is the misuse of our emergency rooms. That we're seeing people who believe that that's the first line of care, is to go directly to the emergency room instead of using clinics, using a primary care provider, working through the system to try and improve their health care. And this is obviously leading to increased healthcare costs. Okay, next slide. The reason that we're talking about this council, and we started with this council with, thank you, Supervisor Burgess, for really kicking this whole idea off. But the reason that we're moving toward this whole issue is because there is this need, and it behooves all the stakeholders that we're talking about. All healthcare can benefit from this. There's some real synergy between Contra Costa Health, the Contra Costa Health System, and Kaiser Permanente, in that they're both preventative care models. So we thought this would be the smart place to start this. We would like to explode this to other healthcare providers, bring in others as we move all this forward. But this should lead to improved efficiencies, more appropriate use of the existing facilities that we do have, better client outcomes, which is obviously one of our biggest priorities that Supervisor Burgess keeps hammering on, make sure that that's in there. And the promotion of prevention models, making sure that we're not looking at this just as care, but actually moving forward and moving ahead of the game with prevention. And then ultimately, this should lead to healthier communities and resident empowerment. Great, next slide. What came out of this is the development of a healthcare literacy campaign that would be led by a healthcare literacy council that we wanted to talk to you more about. So next slide. What we've been talking about, and these conversations that we've been having, is really looking at a pilot campaign to see what this might look like, to see how it could effectively attain the different goals that we outlined, and make a real difference. This would be what we're identifying right now as a 3-year campaign. This would it'd be an integrated outreach and education campaign that would help impacted communities access their healthcare. It would utilize the key influencers and existing resources, and I'll talk more about that in a second. We also know that this needs to be culturally appropriate, that we're dealing with populations that have different language issues, different cultural issues. We need to work within those realities to try and move all this forward. And by the same respect, we want this to be a community-based program, not owned exclusively by the healthcare system, but really bringing the community to play a role in trying to move all of this forward. Next slide. And again, what we're talking about right now, we have a list of about 20 different organizations that ideally would be players in all of this. What we wanted to do is start with a core council where we could work out exactly what this looks like. We could start looking at what curriculums might be, how we might do some of these outreach. And right now, what we're looking at is the core of the council would be Supervisor Burgess's office. Burgess, sorry. Thank you. Just kept coming in. Yeah, okay. Clear that up. Kaiser Permanente and the Contra Costa Health. Again, the point here is there's a commonality here in having systems that are all dedicated to prevention and looking upstream at these activities, not just at the care, and also with a real commitment to the community and the health of the community. Next slide. So 4 different strategies I'll go through. We can go skip on to the next slide. One is the formation of an actual healthcare literacy council that we would like to put in place to start to lead this whole program forward, to figure out how best to do this, to develop the different curriculum, and to outreach to different partners who can really be successful in moving all this forward. That council would be responsible for all the direction, the oversight, and support. Elements of this that would come from the council would be development of the tools as well, the different outreach tools that we need, including a website, social and traditional media. Probably the biggest piece of this that we're looking at right now is curriculum development. And I'll talk a little bit more about what that looks like, but we really believe we need to have the right curriculum to bring to the community and be able to help them understand how to use their healthcare appropriately. And then finally, the recruitment of college educators. We believe that this brings this into the community and it takes it from being top down to being much more lateral type of a educational approach. Next slide. So the second element of this is that healthcare education. We're looking at creating navigation system that would help people who are trying to, especially this Medicaid, Medi-Cal population, helping them understand and connect with the healthcare system. We'd have navigators in place who help direct them, help them answer their questions. It might be hotlines to try and address this. There's also specialized support for those vulnerable populations, whether we're talking about cultural, the economic, language, and even transportation issues, trying to address those and move all that forward. This healthcare curriculum would be helping to instruct the vulnerable populations on how best to use this and giving them the support and the guides to try and move all that forward. Next slide. The other piece that we're looking at is the development of healthcare literacy ambassadors. I know Contra Costa Health already has health ambassadors. This would be similar type of idea. What we're looking at, again, is to make this a community-owned and engaged piece. So what our plans would be is to work with Los Medanos College, work with and recruit students from there, retain students, train them to be trainers, and then they'd go out into the community. The council would help set up meetings. So whether this is at senior centers, whether it's at cultural organizations, wherever it might be in the community, we'd organize those meetings. Then these trained ambassadors would go out and actually train in programs. We'd have programs in place which would help train people to understand how best to use the healthcare system and what the advantage for them is. How in using this appropriately, they can get better care, they'll have less anxiety, things will go smoother for them as we move forward. And then they would also serve as a conduit because they're out in the community, working as ambassadors in the community. They'd come back to the council and tell us what's working, what isn't working. Again, we see this as a pilot. So the point is to see how it best works and to be able to tweak it as we need to tweak it as we move forward. Our sense is that this, again, by having these Los Medanos college students in place, we really have a much more of a community engagement. It's owned at the community level. These are the same people who may be working throughout the community, not just in doing trainings, but also in being able to speak to their community, speak to their families, speak to their neighbors about how to do this so that it has more legs and stretches further. And next slide. So, and then there's the entire community outreach and partners. And as I mentioned, we have a whole list of partners. We want to bring them on when it's appropriate to bring them on. This is still at a early stage. So we don't want people frustrated as we try and figure out all the pieces and try and do the research and elements to move forward. But soon we'd like to move this forward. Our sense is probably by September, we'd be starting to actually run pilots and move it forward. We'll bring our partners on in this interim period to help us to bring in the support, the resources, the knowledge that we need to try and be more successful, and most of all, the connections in the community. All of this information would be shared via social media, on websites. We're seeing videos being produced that would be simple videos to help people as well. We're probably looking at a direct mail campaign as part of this as well. And there may be, we may go to apps. We're looking at a whole host of different things. Again, as we bring more partners in, I think we're going to start to see where the richness of their knowledge and their capacity is to try and bring all this forward. It's that recruitment of additional partners, though, that will be a next big piece of this as we move forward, making sure that we have the right players in place and that this really is a community-owned approach as opposed to just the initial three entities that we're talking about. All right, next slide. Our thoughts are, if this, as the council comes together, what we think we can achieve through this healthcare literacy campaign and the council is empowering residents and letting them better navigate their healthcare systems. We also think that this should lead to a trickle down. We know that we can't reach every single person that we're in the community, but what we want to do is be able to have a large enough body of people so that it starts trickling down. So people are talking to their families, they're talking to their neighbors, they're talking to their coworkers and starting to spread this information. And we know that that should be a successful network to try and move the information forward. Ultimately, what we really want to do is make sure that the community understands how to use healthcare, gets the most for their healthcare investment, and that the healthcare systems are seeing that the system is being used in its maximum sense and being as positively used as possible. And then we also think it's really important to try and find these ambassadors, these young ambassadors who can be emboldened with knowledge and experience and help move that forward, that it gives them a chance to become a leader in healthcare literacy in their community. So those would be the 4 components that we're looking at and trying to move all of this forward. It's a simple in concept, but there's a lot of steps to try and move all that forward. We can go to the next slide. As I mentioned, we're seeing this as a 3-year pilot. This would be in the east part of the county. We'd be executing this. Year 1 would be largely laying the groundwork. That includes curriculum development, recruitment of ambassadors, recruitment of partners, development of different materials so that we're ready to launch out. Our sense is that by the fall, we'll start to actually begin this program. But by year 2, we'd be in full execution of the campaign. So everything will be happening in year 2. Hopefully we will be in the field, we'll be working in the communities. We will have our ambassadors in place. We'll be covering the airwaves with information and making sure that the key audiences here are reached. And then finally in year 3, we would continue the campaign, but we'd also have an evaluation component in place, and we'd be starting to evaluate it. We want to make sure we're evaluating because ultimately we believe this could be something that could stretch out to the entire county. So once we've taken it through a 3-year, by year 3, we may want to look at this and say, we're seeing the results that we wanted to see. We're seeing people better using the healthcare system. We're seeing that ED usage is dropping off, and instead we're seeing people working through clinics, working through health providers to get the preventative care that they need, and then we can make the decision to try and expand. Next slide. Just to give you a sense of cost and what's actually going to be happening. So in year 1, we've estimated a cost of about $95,000. This would be for research and exploration, the development of the council. We're right now starting on some researching on curriculum development and what that might look like. That would lead into the education materials that need to be developed and developing those and designing those. And then the initial recruitment of ambassadors. Next slide. Year 2, because we're in full execution, we're thinking this is about $225,000. This would be for training the schools and seniors. So working with different schools, with different seniors to make sure that the curriculum is being put in place, that our ambassadors are out there providing that level of education, that there's outreach and education materials.
When you say seniors, are you talking about high school seniors or?
Oh, I'm sorry.
Elders.
I'm sorry. No, I'm talking about seniors, older Americans, older adults. Thank you. We'd also be looking at the recruitment. Year 2 will be the continued recruitment of partners and funders. And then the evaluation benchmarks will be in place as we open up year 2. So we start to have a baseline and understand how we evaluate this. And then the full public outreach will be taking place throughout year 2 and year 3. And next slide. And then finally, that year 3, costs come down because the recruitment has already taken place. A lot of the initial work is in place. This is now just moving everything forward. We'd be training across the region. We've got a cost. This would probably cost about $100,000. There'd be active community outreach. Evaluation of the success would be taking place as well. And continual look for recruitment of additional funders for all of this. and then the consideration of whether we want to expand it throughout the entire county. And final slide, I think. Oh, just sorry, not the final slide, but what the evaluation that we're looking at right now. I like Bamil's looking up going, evaluation, he's here. We'd be measuring several different factors, including partnerships, how many partnerships were developed, how activated were they. There'd be class evaluations for each of the courses that we're presenting. We'd have ambassador feedback. What we'd be looking at the ED usage and seeing if the numbers are dropping on our ED usage. We'd also be looking at website analytics, media impressions, and then we'd be doing some pre and post surveying as well. Next slide. So that's basically what the Healthcare Literacy Council is all about. What we're considering right now as we try and move forward on all of this. We actually are looking at having our first our meeting where we'd love to have Contra Costa Health at the table at our next meeting, which is Monday, April 14th at your office. That's basically what we're looking at. So I'm happy to take any questions or Deneen or Supervisor Burgess.
Burgess. And you know, it's funny. I always get a little nervous when I have to say someone's name and I always say it wrong. So when people say, I'm like, oh, okay. But yeah, anyway, go ahead. Let's see. We're going to pass this down.
Okay. Thanks. That sounds like an amazing and so timely program. So that's very exciting. I just wanted to mention, I'm glad we have Kaiser here, that I've been on a number of meetings and calls with West County because, as you know, we have a significant issue there with this very problem where since doctors closed, Contra Costa Health patients largely do go to the Kaiser Richmond ER, which is really inundated. So we're part of the initiative is to help our members learn, that they really need to go to our services. I know Lifelong is having the same issues. And so it would be exciting to expand this to the rest of the county, but I congratulate you on the program.
Thank you so much, Dr. Sullivan. Exactly took part of my comment, but I just had a few comments and clarifications from. Thank you. How large is the pilot at the beginning?
How large?
Yeah.
Like how many people?
Mm-hmm.
Well, we're looking at basically from Antioch to Brentwood is the area, the region that we're looking at moving this through.
Thank you. And I feel as a second comment right now, misinformation is really key as a content. And so I wonder from your point of view, how you can, this is a little bit in the weeds, but important because the content matters about what the ambassadors are going to bring to the community.
Yeah, this is exactly what our thoughts are as well. It's why we wanted to, we felt that it was so important to have both Kaiser Permanente and Contra Costa Health in the development of that curriculum to make sure it's the appropriate curriculum, that it's again, both culturally appropriate, but also the content is accurate and it resonates with what the users of the system are actually encountering. So we have not started any curriculum. We're actually doing research now, but that's the next step, is to start to really understand what is the right content, what are the right messages, and how do we want to try and move people through the system.
Thank you. And third and last is part of what the West Contra Costa issues have been and how we can help be a part of that conversation, but also leveraging what's already there. I just wanted to highlight, as part of Lifelong being a part of the community already in a community clinic setting, we work with a lot of our patients who have been champions with their own health issues and create out of that space promotoris system of health promoters within that have invested in themselves, but also are eager to take that success to their communities. So I just wanted to highlight that.
I'm really glad you did say that. I think that was left out of this, but I think the Promotores program has been such a strong example of exactly what we're looking at, and that we'd want to propel that forward, as well as we probably want to use some of that as in some of the promotional pieces as well. So when we're talking about making videos, it may be with the Promotores to try and showcase what this looks like. And obviously, because we want to do this, this can't just be in English. It's going to be bilingual or maybe multilingual. We did definitely want to try and work with something like that. So thanks for the recommendation. I appreciate it.
And I think it's a great idea. I think it's something, it expands. Of course, during the pandemic, we were spending a lot of time doing education, and CC Health did do a lot of great messaging and utilization of ambassadors, and we can build on that. I'm always looking at things, well, so how are we going to pay for it? It's a relatively modest budget of, $425,000, and not sure you can get all of that done for that amount, but maybe you can. But then where are we getting the money? Have we identified different sources? Obviously, in this time when we're seeing potential cuts in so many areas, it's always who's going to step up and help pay for this. So that's my question, if we've identified potential funding or grants.
You'll need to speak in a microphone. But while you're walking up, I will say that, yes, this is going to cost money. I know Kaiser's going to talk about what their commitment is. We wanted to bring this to the health plan to see if it would be something that we would want to invest in, and if we had the ability to. I can also say that one of the components of the system is, as we've talked about, is the emergency room and ambulance service. And Contra Costa Fire is interested in participating. It's adding to the message, but it's absolutely related. So, but I'll let you go for it.
Hi, I'm Deneen Wolford, and I'm the public affairs lead for this service area. Closer? How's this? Oh, make it comfortable. Okay. Can you hear me? Okay. As we have grown and evolved, Kaiser Permanente understands the communities and what the impact of the current environment is how it's impacting our communities. We are committed to really making a difference. And so when we met with Supervisor Burgess, we talked a lot about how we are similar in our thinking around Contra Costa Health and Kaiser Permanente, along with the need for education of our members and our new members. And that we are seeing so many that don't understand the preventative model, because this is the first time that a lot of our new members are seeing a preventative model in action. So we committed to the seed money for this effort because we are committed to this really important work. Supervisor Burgess really brought in that says, Kaiser can't do it all, but we can lead and we need help. So we're looking to help and partner with other organizations, to really make this really even bigger. And our hope is that we will expand it throughout the county, including West County.
And do you want to talk about your participation in helping pay for this?
Yeah, she said seed money.
Okay.
What's your seed money? Just give me a number. I really.
Okay, we have committed to the first year right now. So that 95,000 we have committed to. So we're going to do this one way or the other. The next 2 years we're going to have to see how we can continue and show the results that we can continue this pilot.
So the question, and I don't know the process of, going over how we would pay for it or contribute to this. And if it's something that the committee and the health plan wants to do, But like I said, I know fire is interested in participating. And so then I just want to kind of go over some other things. These costs are really investments because they actually help lower costs. And when I introduced it, I forgot to talk about that part because as a human, I'm really interested in making sure everybody's healthy and feels good and has, that certainty. I think about the healthcare workers and I think about the system, but I didn't talk about the cost. And so this is an investment. This is an investment in helping us have a more efficient system. It has lower costs for our the clients that we help, and it has long-term savings for our workforce as far as mental health and physical health. And so to me, this is an investment that really invests in our system stability. And I will say, our folks talked about West County often and how there was a need. So just so you know, this is just something that I've been personally carrying. And so I think they were willing to work with me on this, but there's definitely an interest in expanding it throughout the whole county and maybe even through the state if we can have metrics and measurables that show that it's having the impacts that we want, whether it's helping lower costs, improving healthcare, taking a load off of emergency rooms, that whole system. And so, yeah, the metrics are going to be important and the curriculum's going to be important. So those are my comments. Are there other questions? Are there any? Dr. Levin, okay, I thought you were getting ready to, are there any other? So the only other thing I want to say is the way this is set up is that we are helping bring college students from our junior college in, which is going to give them some expertise, some understanding. They're personally going to be better at managing their healthcare, but they're also going to be learning how to do some really important skills for the workforce. Then we're going to be working with high school students who are going to have similar benefits, but there's also the ripple effect because some of these folks are going to have family members that are maybe undocumented and so, or language challenged, or have, grandparents or, all of these different things. So there's going to be a ripple effect because these are going to be folks, again, that are learning how to be advocates and experts, but also are going to be able to show up at their church or their club or their whatever, and they're going to be able to help share that information. The other part of it is people that are recently insured, whether it's folks that have recently gotten Medi-Cal, Medicaid, Medicare, they may never have had that stability. And so it's helping them learn. It's also people transitioning into Medicare who, may have had traditional health insurance. So it's an opportunity to kind of reach people that maybe haven't thought about it. And so to me, this is an investment in giving kids, older folks, college students exposure to these important things, but it's also a workforce thing that gives kids, the courage and strength to go out, and maybe it won't be that they'll work in healthcare in the future, but they'll have those skills. And we're creating a whole hopeful generation of people that are better at managing it. So that's kind of my, that's my hope. So I think this was just a presentation. There was no specific ask, but I would like for it to come back from staff to analyze if there's any kinds of pools of money that could come into this and what those pools of money would be. And then maybe we could also talk about kind of the next steps as we're developing it, where it could go to West County. So is that,
Yeah, I was just going to say here, obviously health has different pots of money for different ways of doing outreach. But I think it's also the Board of Supervisors through Measure X. We're already spending a lot of money right now with healthcare access, with groups that are helping people sign up for our healthcare as well. So I think there's some it's not the innovation grant, but potentially there's one-time Measure X money or something else. It falls in line with what our Measure X cap is identified as a need of the community. And so I think, it could even potentially, you could bring this up during our budget discussions about Measure X, about whether we could allocate some of that one-time money. And my only request is that we do it sort of like I did before, although it's part of the budget cycle, that we just ahead of time have a presentation for the full board ready to go so that they can talk about it.
and if you look at the, there was a list of potential partners, and a lot of those potential partners are Measure X recipients. So, yeah, I will explore that on that level too. But I do think that the health plan needs to be a lead on this as well. Dr. Lowe.
Dr. Lowe can talk.
Near a microphone. No, this was a wonderful presentation. It really speaks to the heart of who I am as a physician and who I'm sure all of our physicians here are in terms of what we need to do to help our community. I'll take this back to our finance team to explore what potential options we have to be able to support this initiative.
Thank you. Are there any other comments within the room? I don't see any. Are there any public comments?
No public comments.
Okay. Did you want to do anything else on closing this out?
No, only we are looking at that April 14th meeting. So if we could have representation from Contra Costa Health at that would be terrific. We'll get you more information about that as well. Great.
Thank you so much. Okay.
I just wanted to say thank you to everybody here. And I really look forward to our ability to partner even more. We have a great relationship with you. And I think together we can make a difference. Thank you.
Thank you. Right. We're going to move on to item 4.0, Interim Chief Executive Officer / Chief Medical Officer report.
Good morning. Thank you. These slides were made when I was pre-CEO and post-CMO. So I will be serving as our interim CEO. Next slide, please. So wanted to provide everyone an update on some recent staffing and leadership changes at CCHP. It's really important to us to be able to serve our mission to our members and to our providers and also to the greater Contra Costa community. So it's important that we maintain a staffing level that allows us to be able to serve that mission. So we've made some great strides in the past month to really grow our team, particularly in the area of leadership. Next slide, please. So of course, myself, I will be serving as our interim CEO. Very excited to serve this very challenging but important role. Looking forward to meeting that challenge and being able to serve our members. They represent some of the most complex and the most vulnerable. So we have important work to do. I want to make sure that we continue to serve that mission. Next, and separately, I want to reintroduce Bhumil Shah. He has served as the Chief Digital Officer of Contra Costa Health for quite some time. Over the last couple of months, Contra Costa Health Plan has embarked upon a new and more collaborative relationship with the Information Technology Department in Contra Costa Health. So because of that, I want to highlight Bhumil, and he is officially our Chief Information Officer for Contra Costa Health Plan. Data science, business informatics, and information technology are extremely important in healthcare and healthcare delivery. So only through a greater collaboration and integration can we really meet the needs of our members. We need to embrace technology and work together to be able to push our mission forward. Also want to introduce Elena White. She is serving as our Interim Director of Operations. She comes to us from Alvarez and Marcel as a consultant. She previously participated in CCHP's operational assessment, so she really does understand where we have opportunities to improve. So really looking forward to leveraging her expertise and experience to be able to push that forward. We really do need an operational transformation, which I will detail at a later GCC, but I'm very, very excited to work with her and push things forward. We are, of course, will be looking for a permanent chief operations officer to continue to meet this need in the long term. So more to come as we pursue that recruitment. Next slide, please. Happy to also reintroduce Dr. Sarah Levin. She has served as one of our Contra Costa Health Plan medical directors for quite some time, with a particular focus on CalAIM programs and the long-term care benefit. In order to clearly divide the CEO role and the CMO role with respect to priorities, we wanted to establish a clear division between business and medical and clinical. So Dr. Levin will now serve as our senior medical director and also lead our clinical operations team. Next, I want to introduce Brandon Engelbert. He had previously served as one of our leads in our claims team at Contra Costa Health Plan. He will now be serving as our Director of Member Services and Outreach. As the previous presentation highlighted, it is really important to engage in outreach to our members. So really excited to have him serve in this role and really boost our Contra Costa Health Plan approach to increasing our member engagement, education, and outreach. Lastly, this is a completely brand new face to our organization, Matt Verdier. He is serving as our Director of Compliance and Government Relations. He comes to us with many years of experience in the California State Prison System. As we all know, our compliance department is an area of opportunity. I'm really excited to leverage Matt's leadership and experience to really build the much needed stability, structure, and organization that we need within our Department of Compliance. So really excited to have these individuals join our team. Wanted to pause and see if there were any questions.
One of the things that I asked Dr. Lowe is for a org chart in the future. And so that'll be available and that'll help us be able to, and just a shout out to Dr. Levin, who's really beloved by the seniors community.
Thank you. Next slide, please. So as a managed care plan, CCHP is beholden to multiple regulators, including the Department of Managed Healthcare and the Department of Healthcare Services. And so it is extremely vital that regulatory compliance is a priority for our organization. Only can we serve our members if we are meeting regulatory requirements and also doing what we need to do to ensure that we're doing things right by our members and also our community. So as the JCC overall provides oversight to Contra Costa Health Plan, I wanted to start a new segment of our agenda, which is to really go over our regulatory audit and investigations. In that way, we can really ensure that we're continuing to provide quality, comprehensive, and accessible healthcare to our members. So as stated, this will become a regular standing agenda item of our JCC. And so I'm very open to feedback on how we can make this better and more informative. Next slide, please. So as previously stated, CCHP has an extremely important mission in serving our Medi-Cal members, as they represent some of the most complex and vulnerable. So in order to do our job and to do our job well, we need to ensure that we are meeting our regulatory obligations. So overall, our state regulators do pursue audits and investigations in order to determine if we are doing our job and doing our job well. So as a result, we don't really see audits as a negative. We see them as an extremely positive and constructive process. It's an opportunity for us as a health plan to continually improve. It's a tool for us to grow, and they highlight areas of improvement and drive ongoing enhancements. It may hurt initially to get some of these findings, but at the end of the day, they've highlighted something that we're not doing well and we need to do better. So we really do welcome these audits. They are frequent enough, but they allow us to continue to process improve as we endure the audits. And of course, no audit is without findings. We would love to have 100% perfect performance on an audit, but we do realize that there are going to be findings, and our job is to ensure that we identify these actionable areas, figure out where we can improve, and actually make those improvements. And this process overall really does align with our commitment.
Before you go on, because this comes up periodically, are you aware of any health plan when it's audited that gets a perfect score?
I haven't seen it recently.
No, and I'm assuming it's not. And it's just, this comes up periodically where people say, oh, you're being audited and look at all these findings and you must be doing so much wrong. But I just want to sort of highlight that point that as you are, this is where we find gaps and this is where we come up with ways to improve them. And it's highly unlikely. I mean, I'd love to find out if there's some agency out there in the state with a health plan like ours that has no. So anyway, please continue, but I just wanted to sort of make that point that these are part of the regular course of doing business, and it's not that unusual.
No, absolutely. And I think that if there has been a health plan that has 100% perfect score, the auditors just didn't ask the right questions. So I think that, I expect and really do want us to have findings, because then we know what we can improve. If they don't check what we happen to be doing or what we happen to be doing incorrectly, we're never going to know. I mean, we are going to start a more robust internal auditing process within the health plan, but these audits really are the ultimate. They're the ultimate authority. They represent our contract, they represent our commitment. So, if they can't tell us what we're doing wrong, we need their help, and we want to continue to do better. Next slide, please. This is a table that really highlights our two main auditors and some of our most recent audits that we've had with these organizations. We have an annual audit with the Department of Healthcare Services, also known as DHCS. They look at 6 main categories of performance: utilization management, case management, access and availability, members' rights, quality management, and administrative and organizational capacity. So as you can see, they really do look at us from top to bottom and bottom to top. They also look at our compliance with our state Medicaid contract, and they also look at how well we've adhered to previous audit findings, as well as any ongoing or closed corrective action plans. So our last audit was in August of 2024. We had 19 findings, none of which were repeat. And we recently submitted our corrective action plan to the state. And we will be sharing that corrective action plan as well as the final report with the JCC members. And I will be detailing these findings more specifically on a later slide. We also have the Department of Managed Healthcare, also known as DMHC, which audits us every 3 years. They specifically look at plan operations in the following areas listed on the slide. Again, a very top to bottom investigation when they do come survey us. Our last audit was in November 2022. They noted 16 deficiencies. 4 they have deemed corrected. The remaining are in progress and on track for closure. We anticipate that they will be coming this year to audit us, as this would be the 3rd year in the rotation. I will be also sharing the final report that they recently provided us with the JCC members. In addition, the DMHC also, in addition to their every 3-year survey, they also do a behavioral health investigation. And we had one most recently in 2023. And subsequent to that investigation, they did give us a report, which I will also share. And then more recently, the DMHC did reach out to us regarding an enforcement matter. They have asked us to provide responses to 32 investigative interrogatories that pertain to this report. And so our team is currently working actively to provide a response and ensure that we reconcile any issues that these interrogatories bring up. I will also be sharing this communication with the JCC members as well to ensure that you have full details and any other background information. Any questions?
It's my understanding that there was a CCHP audit for 24-25 that was published in February of 25, and that'll be also included.
Yes, I will be
Okay.
sharing that.
Okay.
Yes.
Yeah, I'm just going to ask one more. I'm used to interrogatories being in a litigation context. With audits, is it typical for them to present interrogatories? Just that's their term of art for questions that they want you to respond to?
Yes, it does appear customary. I think the DMHC has a significant legal representation in terms of their organization and leadership. So a lot of our communication with them does come in a lot of legalese. We have had a couple of different interrogatories, it appears, over the last few years, and we've been able to provide them that supplemental information.
Okay, thank you.
And I will be providing follow-up.
And in my discussion with Dr. Lowe, we've asked for like quarterly updates so that when we hear about something, we actually can get an update on its status so that we're actually able to track it and that it's being documented.
Yes, and I hope to stagger that with our JCC meetings so that way you are getting more frequent updates than just quarterly. Next slide, please. So given what appears to be increasing regulatory burden from the state and also with our dual special needs plan looming large in 2026 and CMS being a much more comprehensive regulator, it's really asked and pushed us as a health plan to really reimagine, reinvigorate, and really formalize our audit approach. I think our culture at the health plan has been primarily reactive, and we need to be much more anticipatory, much more proactive, much more comprehensive, and our process improvement needs to be more year-round as opposed to post-audit. We have opportunities throughout the year to determine opportunities for improvement, and we need to leverage them and take advantage. So this is a template of what I envision to be our CCHP audit approach. I'm very excited to have a new director of compliance to help us launch this and ensure that we are meeting our needs and making sure that we are, checking up on ourselves. I mean, we need to be accountable to ourselves, but also to our members and also, of course, the JCC and the Board of Supervisors. So as you can see in these different columns, it really does highlight the time period with which we're going to approach the audit and also what different action items occur with each time period. So of course, year-round process improvement. I would like our team to regularly review and monitor our past audit findings to make sure we're continuing to no longer merit those findings, and also, leverage findings that other health plans may have incurred during their audits. The DHCS and DMHC audit processes are year-round. So after us, they definitely audit other plans. Before us, they audit other plans. And, I think it's really important to learn from other people's findings and deficiencies. It's almost a cheat sheet for us. They were asked about this, so there's no reason why we should be asked about it and be found surprised. Also, our team needs to be much more comprehensive in our approach. Pre-audit, we need to be proactive. During the audit, we're asked certain questions and you can see certain themes and certain areas of concern. So we should be making those notes and making those changes as we go. I want to see more real-time improvement. During the audit, they usually end the audit with an exit conference where they let us know some concerns, and that's literally our, time zero. That's when we really need to start working. Oftentimes, these reports come to us many months or even years after the audit, and so you lose the opportunity to improve if you wait for the final report. If the final report ends up showing that we've performed better than we thought, we've also made changes that the auditors may not have thought were that grave.
Yeah, and one of the things we've also discussed is keeping this committee better informed as things happen in a timely manner, and also creating more transparency. So when we receive letters that we need to do corrective actions or all that, that's going to be included in our agendas as maybe either an item, or it could be even put in communications or something like that. So everything is out in the open. And as someone that's been on this committee, I've been saying, I want to see everything. I want to see everything. And so we're going to make sure that we do.
Absolutely. That is our intent. And I think, regulatory compliance is very important. So I do want that to be a regular standing item where we have discussion as a committee. Any other questions before I move on?
I just want to comment, thank you for the organization. I think it's in email and we discuss it, but I think having it as displayed is helpful. Thank you.
Great, thank you. Great, next slide, please. So now I'd like to take the opportunity to get into the nitty-gritty of our recent DHCS 2024 medical audit. And as previously shared, we will make sure that the JCC has that final report as delivered to us by the DHCS. And we will also be sharing with you our corrective action plan that we've submitted to the DHCS as well. Next slide. So just to provide some background for everyone who may not know the details regarding what this audit entails. So the audit took place on August 19th through August 30th, 2024. The period with which they reviewed was the year prior, August 1st, 2023 to July 31st, 2024. And as previously mentioned, they do a thorough review of 6 categories of performance. This includes documentation review, verification studies, and interviews with the plan. It was a 2-week interview process, very comprehensive. We have dealt with some new team members from the DHCS auditing team, and overall it was, I think, a very, very positive experience. Next slide. So what I've done is I've broken down the findings into departmental areas or themes to really delineate what the findings are, how they relate to one another, and also describe our overall approach to corrective action. So in terms of utilization management, this is an area where there's significant opportunity for improvement for the health plan. Utilization management is how we decide how members, whether or not they meet medical necessity or guidelines for services. So this is how people obtain their health care. So this is an important job that we do, and we need to do it right. One of the findings said that our notice of action letters did not meet the, did not accurately or explicitly describe how the member's condition did not meet the applicable clinical criteria or guidelines. And this is a valid finding. Our letters do stand for some improvement, and we are looking forward to making remarkable change and hopefully resolve this finding very timely. The DHCS did recommend to us to revise and implement policies and procedures to ensure that we do resolve this finding. And so what we've done so far is we have revised our policies and procedures. We have provided detailed training to all individuals who participate in the letter writing process. This is a manual process, so we have opportunity to directly intervene. Our nurses and our physicians who participate in utilization management contribute to the letters. So we've provided initial training as well as ongoing training and refreshers as needed to ensure that we comply. Our utilization management team also performs regular monthly audits to determine that these letters meet the requirements of the DHCS for an appropriate letter. Next slide, please. Another finding in utilization management was that the plan did not ensure that Contra Costa Behavioral Health, our plan delegate, sent notice of action letters and accompanying information, including your rights, non-discrimination notices, and language assistant timeline notices for any prior authorization denial decisions. And their recommendation was to revise and implement policies and procedures to ensure that we comply. And so as part of our corrective action plan, CCHP, our behavioral health department within CCHP has insourced all of these utilization management activities. Within the plan, we have very robust automated mechanisms within our electronic medical record to ensure that these letters have all the necessary components. And so we have taken that upon ourselves to manage. And so far, we've been doing very well, ensuring that we're meeting this requirement.
The report that you're talking about hasn't been put out. We've seen it from other sources, but we haven't seen the corrective action plan.
Yes.
So that needs to be done in a timely manner. And is that required for us to, we don't have to be a part of that?
I would like for you to be a part of it.
Okay.
So I think the part of the timing sometimes is that we don't have a JCC that's so
Sure.
timely.
Sure.
I believe we received this report in February and it was due at the end of March. So we did not have a JCC in the interim. So I'd love to work with the team and within the confines of the Brown Act to determine how we can share this information with you more timely and ensure that you are part of the process.
Well, and part of it too is when we know there's an urgency for a meeting, we can move things around. And so we need to understand that there is a deadline for requirements, and that creates some urgency for us.
Right. And I was going to say, typically we have met in March and we didn't because of scheduling issues. But even though we're scheduled to meet 4 times a year, there is nothing that stops us from having a special meeting. We just notice it. And I think Diane and I are both very happy to make ourselves available.
Wonderful. I will definitely take advantage of that. Thank you very much.
Yep.
Any additional questions on the utilization management findings before I move on? Next slide, please. So with respect to our appeals process, we did have a finding, and our members have the right to appeal any negative determination. It is their right, and it is our responsibility to then review their appeal and ensure that we make an appropriate decision. So as part of the DHCS's audit, they determined that our plan did not ensure that the person making the final decision for appeal resolutions did not participate in any prior decisions related to the appeals. Overall, we really appreciated the clarity the DHCS was able to provide our appeals team team during this audit. We have implemented policies and procedures as recommended to clearly delineate the process for who should be and who is allowed to participate in appeal resolutions. We have clearly drawn a line between who has performed the utilization management decision and who is doing the appeal, and they have been 100% across the board different people since we implemented these procedures. Any questions on this finding? Thank you. Next slide, please. So as part of a Medi-Cal's members' journey in a health plan, they are supposed to undergo an initial health appointment. It's an opportunity to really determine what their needs are and what healthcare services that they do need. So it's a very important process. So during the audit, the regulators found that the plan did not ensure that providers documented all required components of an initial health appointment and asked us to implement policies and procedures to ensure that we comply. So our team has done just that. We have revised our policies and procedures and revised our approach to ensuring completion of IHAs, also known as initial health appointments. We recognize that the providers in our provider network are extremely busy. They have a lot of sick patients to deal with a lot of complex issues to address. And so we want to be able to support them in this process. So we have a CCHP clinical quality auditing team, and they are conducting biannual audits on the components that are essential for an initial health appointment. We are going to be providing training to providers in different forums regarding the IHA components, and also through our medical record review process that our clinical quality auditing team regularly performs. We are going to be specifically reviewing to ensure all IHA components are in place. And if they are not, we will work with providers through a corrective action plan to ensure that they meet compliance ongoing. Any questions on this?
I guess, so this is just kind of an ongoing thing. There's no timeline that we have to provide for these different corrective actions.
So we submitted initial responses at the end of March, and it becomes a back and forth process with DHCS. They review our responses, and then generally on a monthly basis, they give us feedback, and then we provide additional responses on any items that they do not deem closed. We were successfully able to close all of our audit findings for the prior audit with ample time before this last audit. And so as we receive correspondence from the state, I intend on sharing that with the JCC members to ensure that you know where exactly we stack.
And so how many providers were out of compliance?
I don't have that exact data on me right now. Happy to share that and look that up for you.
All right, thanks.
Any additional questions?
Yeah, Supervisor Burgess and the others, this has been a particular, I think, pet peeve between the health plan and the delivery system, which is the IHA completion. It has very specific elements that we may not completely understand in the delivery system, and there may be technical improvements like coding and this sort of thing that can fix the problem. So we'll look forward to working together. It's not really a matter of lack of compliance of any clinical duties. It's more like a record keeping bureaucratic matter in large part. So appreciate the collaboration.
Yes, thank you, Dr. Sullivan, for that. So internally, we're going to be meeting within CCHP, determine how we can better support our providers on this. And to Dr. Sullivan's point, a technological solution would always be ideal. Our providers have more than enough work to do, so to make things less manual for them would be great. Next slide, please. So our next finding theme is on blood lead. So I just would like to point out, in speaking with other health plans, this is an area of a lot of angst for all health plans because blood lead is something difficult to operationalize and really be able to get from our providers. So we were expecting this finding, and we're working very diligently to ensure that we can close this finding pretty expeditiously. So our finding was the plan did not ensure that providers documented the completion of blood lead screening tests, and to revise our policies and procedures to ensure that we comply. Our health education team at Contra Costa Health Plan is conducting phone call outreach to parents of children children who are overdue for this. We also share this list of overdue children on our provider portal, which updates daily, so providers have access to an ongoing list. Our CCHP team is also actively working with providers to implement point of care glucose training for lead screening in office. And we also have posted the lead screening toolkit on our health plan website. And we've also met very intensely with organizations that have been our biggest offenders with respect to blood lead. And thankfully, they have come to us as very collaborative partners. So I think we've made a lot of significant inroad since this audit and really do hope to continue to improve. Blood lead screening is important. Next slide. An additional finding we received in blood lead was that the plan did not ensure the provision of oral or written blood lead anticipatory guidance to parents or guardians. And so again, our facility site review team is conducting audits to ensure that providers are doing this. And if not, we will work with the providers through corrective action plans to ensure that they meet compliance. And we're also making sure that education is provided via the CCHP website as well as through other forums to ensure that providers understand and know what is required. So one of those forums is our provider network training. Another is our provider newsletter that we send out quarterly to our providers. Any questions on blood lead? Next slide, please. So our next area of findings were within our enhanced care management program. Our enhanced care management program is a more in-depth care coordination support that we provide some of our more vulnerable and complex members. It provides them a face-to-face opportunity with a lead care manager that is able to much better address their needs. And as part of the program, we are here to provide additional care coordination for non-clinical needs as well as clinical needs and ensure that these members get the support and resources that they need to be able to improve their health. So one finding that the state found with us was that we did not ensure the provision of comprehensive care management and coordination of care for the clinical needs relevant to members enrolled in the ECM program. They also found that the plan did not ensure that all members received all 7 ECM core service components. And they also found that the plan did not ensure that ECM members and their authorized support persons received a copy of the member's care management plan along with information about how to request updates. Next slide. So our corrective action plan has been very comprehensive. And I do want to point out that we were the first plan to be audited with respect to ECM. This is a relatively new program, so we were expecting this at some point, and they did come to us last year for this audit. Since we've been audited, every other plan has been audited as well, and we've taken that opportunity to collaborate, learn best practices, and find out from others what else the state asked them about. We figured that after us, they got some practice and that they had better questions and did a little bit better digging with the other health plans. So we were able to learn a lot. We found that we shared a lot of similar findings and a lot of similar areas of concern. As it is a new program, we anticipated that more work would need to be done to continue to deliver this program well. So we've revised our policy regarding ECM engagement, operations, and evaluations. We really wanted to emphasize our oversight process to ensure that these providers implemented a comprehensive program. We wanted to make sure that they're addressing the clinical needs as well as the non-clinical needs and also address those 7 core service components. They're core service components for a reason, and we want to make sure that they are delivered. And we also wanted to make sure that our ECM providers were accountable for their performance as well. So we've asked that our ECM providers conduct regular internal audits to ensure that their ECM program is compliant. And CCHP is also building into its auditing process as this program has passed its first year anniversary. We are going to be auditing all of our ECM providers after they have been providing service with us for 1 year to ensure that they continue to meet compliance. We also perform monthly complex case rounds with all of our ECM providers to discuss non-clinical and clinical needs of members and to provide any necessary support or resources as a health plan to our ECM providers to ensure that they are successfully coordinating care for our members. And overall, our ECM and CalAIM team are regularly auditing our ECM cases to ensure that we are noticing any positive or negative trends and, of course, execute improvements as necessary. Any questions on ECM? All right, next slide, please. So the next theme of findings was within grievances. Our first finding was the plan did not have policies and procedures to ensure medical quality of care grievances were immediately submitted to the medical director for action. And this is a finding that we really appreciated because it provided us some much needed clarity on process. Our medical directors have always been involved in quality of care investigations. However, they may not have been immediately notified. So we have revised our policies and procedures as recommended to ensure that our medical directors are immediately notified within 24 hours of these quality of care grievances so that they can review and provide necessary recommendations and support, particularly if it happens to be a very urgent or grave quality of care issue. And I think we've been batting 100 since we've done that. Next slide, please. Our other finding in grievances was the plan did not submit grievances alleging discrimination along with detailed information regarding the grievances to the DHCS as required. As we launched our health equity program in office a year or so ago, we really wanted our discrimination grievances to be investigated under the lens of health equity. And so we had been working on revising our process for discrimination grievances to include our health equity team. And it's been a work in progress. And although we've been reviewing and investigating all discrimination grievances, we had not submitted every single one to the state. And part of that was due to a new process, new team. We have since recovered and, highlighted by this finding, we have revised our policies and procedures to ensure that all grievances that allege discrimination are submitted to the state. And again, we've been batting 100% in this as well since the audit. Next slide. The last finding with respect to grievance was that the plan did not ensure all grievances, including exempt grievances, were reviewed and analyzed on at least a quarterly basis. Again, this is an area where CCHP was really grateful for some clarification. Exempt grievances have been an area where we needed some clarification, and we were glad that DHCS was able to support that. So per the recommendation, we have implemented policies and procedures to ensure that all grievance types, including exempt grievances, are included in our quarterly track and trend monitoring report. And just to provide some background for our JCC members, exempt grievances are grievances that are resolved within the first 24 hours. If they are exempt, they're defined as exempt and treated a little differently with respect to member notification. Our routine grievances were given much more time to be able to investigate. Any questions on grievances? All right, next slide, please. So this finding was related to provider preventable conditions. So as some background, provider preventable conditions are conditions that a provider theoretically should have been able to prevent while a member is hospitalized. So if someone does have a provider preventable condition, it does impact their reimbursement. So the DHCS found that we did not report all provider preventable conditions, also known as PPCs, to the DHCS as required. And they recommended that we revise and implement policies and procedures. Again, this was an area where we appreciated the clarification. We have always investigated all provider preventable conditions, and there had been instances where we deemed that it did not meet the definition, so we had not submitted them to the state. However, given the clarity from the audit and this finding, we are now submitting 100% of all submissions, either through our automated report or through submission from other individuals. We're submitting all of those to DHCS. And again, we are batting 100 since the August 2024 audit. Any questions on this? All right, next slide, please. So the next finding was regarding provider terminations. The DHCS found that the plan did not provide written notices to all impacted members for terminations of network providers, subcontractors, or downstream contractors, and they recommended that we develop and implement policies and procedures. So we have since revised our policies and procedures to ensure that the written notification process is clearly delineated. This was an area where we definitely needed the clarification, so we were able to revise our processes and policies in order to reflect what the DHCS requires.
What I'm hearing is like a provider has terminated working and nobody's let them know. So
yeah, so we're required as a health plan, once a provider has been terminated, whether they've done it on their own volition or whether it's a mutual breakup or whether, we've had to terminate them for a different reason, we are supposed to notify our members so that way they are aware. And it does not appear that we were 100% consistent on this. And part of it may have been a poor understanding of procedure.
is that all members or just members that are
The members that see that provider.
See them. Okay, all right.
Yes, I mean, the reason for these notifications is really to ensure that there's no gap in care. Yep. Any other questions on this? Okay, next slide. Our next findings revolve around compliance. So I grouped them together. One finding was the plan did not ensure the designated compliance officer did not also serve in an operational role or capacity. Second was the plan did not have policies and procedures that include criteria for selecting a compliance officer or job description outlining the responsibilities and authority for the position. And the last finding was that the plan did not maintain a compliance program, which included all required elements of a compliance plan. Next slide. So I want to point out that I fully recognize and acknowledge that our compliance program needs work. We have a strong team of staff who are ready, willing, and able, but as a group, we need to work together to build better structure, better organization, better leadership, and better responsibility and accountability. So we are very grateful to have Matt Verdier as our new Director of Compliance to help support and lead that effort. A compliance team is the backbone of our organization. It ensures that we meet all of our regulatory obligations, which then allows us to better serve our members. So our plan moving forward is to really ensure that we have a robust compliance plan and that our compliance and policies and procedures reflect a very robust, discrete compliance program, and that we ensure that our compliance officer is completely absolved of any operational responsibilities. At this time, our compliance officer, Shonda, does not carry any operational responsibilities. And the plan is once Matt has finished onboarding to transition the compliance officer role completely to our Director of Compliance so that the sphere of leadership remains with one person within the Department of Compliance. Any questions on that? All right, next slide, please. The next finding was regarding fraud, waste, and abuse reporting. They found that the plan did not report all suspected fraud cases to the DHCS within 10 working days. And again, this is an area where CCHP really benefited from this clarification from DHCS. We had been investigating all fraud, waste, and abuse reporting, but had not been submitting everything to the state. And I just want to emphasize this fraud, waste, and abuse reporting is when there is a concern of fraud, waste, and abuse among our providers within the network. And so we have revised, as recommended, all relevant policies and procedures to ensure that we are submitting all suspected cases of fraud to the state within 10 working days. Any questions on this? Okay. All right, I think we're on to our last finding. Next slide. This finding revolved around notification of changes in member circumstances. The finding was that the plan did not have policies and procedures to promptly notify the DHCS upon receipt of information about changes in a member's circumstances for income and death. So they recommended that we revise policies and procedures. And again, an area where we definitely benefited from clarification in speaking with other health plans, because I did reach out to other chief medical officers to determine what they do. This is a very difficult process because income and death are not always readily available to us as a health plan. Sometimes we get that information from the county. Sometimes we get that from providers. Sometimes we get that from members and their representatives. So we were able to really develop more robust policies and procedures within our member services department to ensure that we're promptly notifying organizations that DHCS is requiring us to regarding any change in member status. Any questions on this? Next slide. So I'm a fan of tables and graphs. I don't know if you guys have noticed that already. I really wanted to present our audit findings as a progress report and I'm hoping to do this ongoing, so that way you can see a snapshot really clearly of how well we're doing. I'm very happy to report that our overall corrective action plan status is excellent. We've submitted our corrective action plan responses, which I will share with the JCC members, and policies and procedures have been updated pertaining to all findings. Staff training pertaining to all findings has been completed. And in these next 3 slides really do emphasize what our ongoing next steps are. They include a combination, depending on the finding, of internal audits, ongoing provider training, ongoing provider audits, ongoing member outreach, and also just checking up and making sure that we're meeting these responsibilities. Next slide. Again, next steps also include chart review, meeting with providers, and ensuring that we're doing the member and potential family support outreach that we need to do. Next slide. Again, same thing. For some of these findings, we are doing ongoing reporting and also internal audits to make sure that we remain compliant. Next slide. Any questions on what I've shared so far? I know it's a lot.
The other thing, given the time, I think you can also assume that we've all read all of this and that we will highlight, I have notes in places where I want to, because I realize we've got a room full of people. We're usually done close to 11:30
Yes.
and we're 3/4 of the way through the agenda.
Yes.
If even that. So if you want to summarize and highlight the important stuff, things that you think we really need to have highlighted, please do, but just in the interest of time.
Yes, understood. Thank you. So our next steps for this corrective action plan are, as we have shared already, we submitted responses to the state and we're awaiting their responses to see what else we need to do. And of course, we're going to continue our proactive approach to audits moving forward and also being much more transparent and communicative regarding our ongoing progress. Next slide. So I wanted to take some time to provide an update on the focused audit that we performed of Contra Costa Public Health ECM services. Contra Costa Public Health is an ECM provider for Contra Costa Health Plan.
Process. These are all different items listed on the agenda. And so I'm going to stop because we just went to 4.4. And I'm going to ask for public comments on items 4.3 and whoops, I'm on the wrong pages. I just want to make sure we're operating properly. So you did 4.1 and 4.2.
Yes.
So I'm gonna just stop there. There's no action required, but I do want to give the public comment time just in case. That way it's not overloading everything. They forget they wanted to ask a question on something specific. Thank you.
Thank you.
Are there any public comments on those two items?
No public comments.
Okay, thank you.
Thank you. Thank you for
Want to
keeping
make
us.
sure.
No.
Yeah.
So next slide. As background, during their audit, as previously shared, DHCS found 3 findings pertaining to Contra Costa Health Plan's ECM program. And overall, CCHP recognizes its important role in ensuring that the ECM benefit is provided to Medi-Cal members and provided well. And we're intent on ensuring that the appropriate monitoring and oversight mechanisms are in place. So given the significance of these findings, we proactively performed a focused audit of the Contra Costa Public Health Department to ensure that public health had made the mandatory improvements in its provision of ECM services. And just want to provide some background. We had previously audited Contra Costa Public Health as part of our standard auditing processes. So this was a focused audit within an audit to ensure that Contra Costa Public Health was maintaining its compliance to the corrective action plan. Next slide. So just some audit details. Happy to entertain any questions on this, but we really just wanted to make sure that Contra Costa Public Health maintained its program and that the program itself was meeting all regulatory requirements. Next slide. So just wanted to summarize for everyone the audit findings that we found during this focused audit. And as it was a focused audit, we really wanted to concentrate on elements that really did pertain to the 3 findings that DHCS had given us with respect to ECM. And we're very happy to say that Contra Costa Public Health has made significant and frankly commendable improvements in the implementation of their ECM program. We saw improvement in their assessment of non-clinical needs and clinical needs. We saw improved care coordination. We saw improved connection of the member to their PCP and other clinical team members, and we also saw improved provision of care plans. The Public Health ECM Corrective Action Plan is still ongoing, and so as we complete that, we will provide an update to our JCC, and then we will also share the final report from this focused audit, as well as the original audit report to JCC members. That way you have that as background.
And so this was probably a good point to see if there are any other questions on this particular item. And for me, it's really helpful to have these in front of me, and I really appreciate the updates that we will continue to receive. So any public comment in the room? Any public comment behind me on the computer screen? Any hands raised? No hands raised. Okay, continue. Thank you.
All right. This is my last agenda item. I wanted to provide the JCC with a high-level update on our project plan and strategy for the Medicare Medi-Cal Dual Special Needs Program that we are required to launch in January 2026. Next slide. Next slide. This is just a summary of what the Medicare Medi-Cal Dual Special Needs Plan is. If there's any questions on just this description, happy to answer those questions now. Otherwise, I can move on to the next slide.
And I want to thank you that the description was very clear, because at least at first I was a DSNP. What is this? And then it was very clear, special needs population. So thank you for making it clear in the packet.
Of course. Next slide, please. So this slide just delineates what it means for someone to be considered eligible for the dual special needs plan. Of course, they have to meet requirements for Medicare and Medi-Cal, and it really allows us to hone in on an especially vulnerable population and to provide additional care and benefits. Next slide. And these are specifically delineating the different benefits of a dual special needs plan to not only the member, but also to any providers that participate in the care of these members. Are there any questions on this slide? All right, next slide, please. So as a DSNP plan, a dual special needs plan, we're required to have a special name for that line of business. And so we've been working very closely with Brown and Miller Communications on developing this name. And it was frankly the most remarkable conversation I've ever had, because there's so many different ways you can name something. I don't have any children, so I haven't named something, but this felt like a child. So we really wanted to emphasize a few, yeah. We wanted to really emphasize a few key points. We're representing Contra Costa. We're representing health. We're representing healthcare, and we're also doing more. This is a vulnerable population, and we're providing expanded benefits, programs, and services. So this is our name, and I hope it meets your approval. But we're very excited that come January 2026, we'll be launching Contra Costa Healthcare Plus. Next slide. The next couple of slides really delineate our approach. Our focus for the dual special needs plan is really to ensure that it's member-centered. We're looking at our membership to determine what their needs are, so that way we can build a benefit plan that meets their needs, make sure the formulary of medications meet their needs, and that we provide supplemental benefits that meet their needs. We've had to create a model of care that delineates how we deliver care coordination, and we've also had to work on building a provider network and a member support structure that will really engage and support these members. Next slide. This is also a multidisciplinary team approach. This is a team sport. In no way can CCHP do this alone. So we have engaged our provider network, provided initial education, information, and we've particularly also done some work in engaging and collaborating within our delivery system. Right now, as Contra Costa Health Center and its, Contra Costa Regional Medical Center and its health centers carry the large majority of our primary care membership, we want to make sure that, obviously a lot of these members will translate hopefully to our DSNP plan, that we are engaging those providers and they're part of this building process. So we're very excited. Next slide. And this slide just kind of gives a very busy but delineated list of all the milestones. I alluded earlier that, CMS is a much more comprehensive regulator, and they have obviously, as seen on this slide, a lot of milestones and requirements for us to check and do to be able to launch in January of 2026.
So looking at all those deadlines, some of them are literally weeks away. Are we
We're on track.
Okay.
The next couple of slides talk about how we are monitoring and overseeing and actually building the process of implementation. Our DSNP steering committee is made up of C-suite leadership as well as key directors as well, to ensure that we're meeting all necessary components of our DSNP implementation plan and that we're meeting all of these regulatory guidelines. Next slide. Yes, so we also are working very closely with Contra Costa Health IT and Epic, which is the company that owns our electronic medical record.
Going back to the previous
yes.
slide, 89, are all those positions filled?
Yes. Well, instead of a chief operations officer, we're leveraging our director of operations to fulfill that role right now. And then as I'm the interim CEO, we do not have a chief medical officer, but Sarah Levin will serve in that capacity as our senior medical director.
Okay.
Other than that, these are all filled.
Okay, just want to make sure.
Thank you. Next slide. So we're working closely with Epic, our electronic medical record, to make sure that we're building processes and a medical record that will allow us to do our work for our DSNP members. Next slide. Operationally, there's also a huge lift. So we're really asking our departments and our departmental directors to really help lead the operational implementation efforts. And so this is just an outline of how these work groups are formulated. Next slide. That's all I have. I'm so sorry I talked everyone's ear off this morning, but any questions on the most recent topic?
We can't ask you to be better or communicate with us and be more transparent and then criticize you for talking too much, right? Can't have it
I
both
may have set you
ways,
up for that. Yeah.
right? Right. So I really appreciate you going that. I know we'll have more questions. I know, I've asked to kind of raise the bar on some of this, but I appreciate you speaking. Are there other comments?
No, I was going to say I appreciated the clarity of the reports, the written as well as the presentation. And I think it's important that we have this in recognizing we dragged it out by our conversations as well and our questions. So thank you.
It's just, it's hard, it's long, but it's refreshing and it inspires confidence. So thanks for the transparency.
You're welcome.
And we can always budget more time for meetings too,
Yeah.
which is just so people have the expectation they'll be here till 12:30, or we can start earlier. We could start at 9, at 8:30. So
Or meet more often if
Yep.
if there's that need as well.
Absolutely happy to. Thank you.
No public comments. Thank you so much. Thank you. Thank you. You can go to the next slide. Hi, I'm here today to talk about our quality program description, work plan, and evaluation. So every year, the health plan completes a trio of documents with the approval of our quality council, which is a team of network providers and plan providers. We look at last year's quality program across the health system, quality measures, safety issues. We see if there are any changes that are needed to that program to create a program's description, and then a work plan for the following year. You can go to the next slide. So just some brief highlights to our evaluation from 2024. Every year we submit a number of quality measures to the National Committee of Quality Assurance, and we did rank 4.5 stars out of 5. We're one of 14 health plans in the country of our quality ratings. We had 17 measures that were in the 90th percentile, which I'll talk a little bit more in the next slide, but that means only we were in the top 10th percentile of all national health plans in some of these measures. There was a significant expansion of CalAIM's services with CCHP and a very big focus on internal infrastructure with regard to a pay-for-performance program to starting that and data sharing with providers. You can go to the next slide. So these are some of the measures that network providers like CCRMC and Lifelong helped rank these so high, but due to the wonderful work that they do every day. Again, we were in the 90th percentile for measures like breast cancer and cervical cancer screening, well care visits in the first 15 months of life amongst prenatal and postpartum care. We did have two measures that were under our minimum performance level in 2023, which was lead screening and topical fluoride for children. I'm proud to say that for 2024, our preliminary data, we are over in both of those with a 14% improvement in lead screening rate, which was a big improvement to these two providers right here for the work that they've done over this year. Next slide, please. Looking at our quality plan, we cover a number of areas ranging from measurement, performance improvement, population health, and engagement with providers. You can go to the next slide. I think some key focus areas for this year is our plan is up for NCQA accreditation for both health plan accreditation and a new equity accreditation. This is a huge body of work. It is not an audit, it's a survey, but it feels very much like one. So we are working with all the departments to be survey ready. We're also working strongly on DSNP, maternal health projects, and launching a pay for performance program with our community provider network, if you go to the next slide. So one thing I wanted to note is historically, CCHP has been providing provider incentives to the community provider network based on a capitation payment based on their panel size. And so this is a big change this year that we are moving to a pay for performance program based on a set of quality measures and achievement. And so we have a phased approach for rollout. We had 2 providers, Lifelong and La Clinica, join in 2024. We're going to have 8 providers of those with have 2,000 or more patients signed in 2025, so this year, and then we'll be moving it out to all of the other providers in 2026. Next slide. So we expect this to help our quality measures even more with this pay for performance program. We're meeting regularly with providers. We're providing data back to those providers on our provider portal and working with the providers in our performance improvement projects. Next slide. And now I'm going to submit these to the board for the approval of these documents. Were there any questions? Sorry, I should have asked that first.
I guess my real question is when you're shifting from the capitation base to actual performance, all of that, has that been a burden for the providers? I mean, it's a tracking thing as well as just a financial budgeting thing as well. And so how did that navigate?
Sure. I think we met with all the providers beforehand to talk through these changes. I think in general, the providers are already measuring many of these things. The FQHCs report these to the federal government through a system called the Uniform Data System, or UDS. I think this is an opportunity to align more and offer some more data sharing. But I'll leave it to Dr. Cece because she can talk a little bit more about her experience.
I'll just make a comment, actually, and I appreciate Beth's leadership because I think what has bridged our gap is a few things, Epic, but I think ultimately she is very hands-on and has been very engaging for our team at Lifelong. So I just make a comment because, yeah, the partnership matters. So.
We didn't do any public comment on this item. Were there any public comments?
There's no public comments.
Behind us, she had done.
Okay. All righty, so we will now move on to item 6.1, behavioral health focus audit update. Still morning? Oh yeah, you're accurate.
2 minutes in your presentation.
Excuse me to interrupt. Dr. Barcelo, we cannot hear you.
Microphone, is the blue light on?
Hello, can you hear me?
Now we can hear you.
Okay.
Yes.
Nicolas Barcelo, Medical Director, Contra Costa Health Plan. This is an update regarding the focused audit conducted by DHCS in August of 2023, for which Contra Costa Health Plan received a corrective action plan in the summer of 2024. We've spent the last several months addressing concerns identified by the auditors in this audit, and this is an update on our progress. Next slide, please. So the next 2 slides are very simplified schematics just to reorient the committee related to how Medi-Cal members with CCHP access mental health services. In the 3 purple rectangles, you can see areas in which the department identified opportunities for the plan to better coordinate services. That relates to entry into specialty mental health, transitions between specialty and non-specialty mental health, and inpatient discharges. Next slide. The department additionally identified new referrals into substance use services as an opportunity for improvement. Next slide. So, in order to address these caps, the plan took initiative in increasing staffing, increasing IT capacity for tracking, monitoring, documenting, and really a lot of interdepartmental collaboration with behavioral health services to address member needs. And I'm happy to say, if we go to the next slide, that in the time since these slides were prepared, CCHP has effectively closed each of the 5 findings related to this coordination. So we received communication from DHCS that all but one element of 2.3 were accepted as satisfactory to the department. If we go to the next slide, we can provide just a preview of data that was generated, and this is pending QC, but it shows by month the number of CCHP members who were referred to substance use disorder services, the number that completed those referrals, and there is ongoing collaboration with DMC ODS to take steps to identify what were the barriers to completing those referrals and how can we increase those percentages even more. Any questions regarding the focused audit for behavioral health and substance use?
Yeah, just as kind of a, as we're revamping and doing this, the staff report is really important. This for the public to understand what it is. So through my staff was not sure what we were referring to as far as the what it wasn't clear what we were addressing, and so it'd be great to be able to provide a little bit more context in our agendas to explain what we're talking about.
Absolutely.
Thank you.
Okay. If there aren't further questions, I think we can move to the next section. Next slide. So this is an update regarding progress, tracking and trending, grievances and appeals processed by the plan. Next slide. So we'll start with member grievances. Next slide. On the whole, in 2024, and again, this is as of Q4 of 2024, this update, we saw relative stability following a change in workflows in March in response to our prior routine audit. And that was a reclassification of a certain type of member complaint that resulted in that peak in March and then relative stability throughout the year. And so I think that the percent increase year over year between those December time points is a little misleading. I think that, generally speaking, from the end of Q1 moving forward, we saw numbers in the mid hundreds. Next slide, please.
And didn't we see an increase in membership too?
I can get back to you on that question. We do have in a subsequent slide a rate of grievance per membership. So it'll account for that.
Excuse me. Well, the other question too is, were we identifying more grievances? Was the number of grievances really the same, but because we were changing the classification of them, it showed a higher number? Because 276% increase is a huge increase. And to Diane's point, obviously, if that's right, when we're enrolling more members, you could percentage-wise expect that.
Right. Our analysis thus far has shown that the increase is attributable primarily to the reclassification.
Okay.
So we were seeing the same number of grievances. Those
Right.
concerns were being addressed via a different avenue.
Right,
And
but
so
they were
now
just
we're
now
calling
classified.
them.
Okay.
Correct.
That's
Yeah, and it seems like I remember in our last meeting having a similar conversation, maybe putting a little star or something. Because again, what I'm looking for is when the public looks at this, are they going to understand the context, the changes, all of that?
Right.
So.
And we will have a subsequent slide with the requested adjustment per enrollment coming up. So this is just to show that the majority of grievances we receive are not expedited. Additionally, to underscore that exempt and refuse to file grievances are now being trended in a more consistent fashion, and that was one of the routine audit findings in our most recent conversation with the department. Next slide, please. The majority of our slides relate to quality of service, and if we go to the next slide, we can see that the primary driver, excuse me, I misspoke. The primary driver for the quality of service complaints is related to billing, and that is upcoming. We do track quality of care grievances to identify opportunities for our providers to better interact with patients. These grievances are reviewed by medical directors and provided input on the investigation and exploration. Next slide. This is the slide underscoring the extent to which billing issues, which were the reclassified type of grievance that led to the increase in Q1 of 24, really significantly outnumber those related to quality and care. So diagnosis and treatment at the top of this graph is one of the most common types of QC grievance. However, relative to those billing issues, it is really quite small in number. Next slide, please. So here we have a grievances per 1,000 members, and so this will account for changes in membership. We do see that the commercial population of CCHP submits grievances at a rate higher than the Medi-Cal population, and we'll continue to trend this and conduct further analysis in terms of, are there opportunities to support our commercial members perhaps a bit more to address these grievances. Next slide, please. Okay, member appeals, next slide. So these are in response to instances where an authorization request has been denied or partially authorized. We have here a breakdown of those for commercial and Medi-Cal members, the majority being routine appeals for Medi-Cal members. Next slide, please. Trending over time between standard and expedited, we do see that the majority are related to services that were denied. Next slide. And here we have what has been something we're looking at as an opportunity for improvement. What is the overturn versus uphold rate? In the next presentation, I would like to present a slide breaking down why appeals were being overturned. These tend to relate to access as opposed to an inappropriate decision being made in UM prior to the appeal. And finally, we have a per 1,000 members by line of business. We can see that, again, the commercial plan, despite being smaller, appeals at a greater rate for its membership. And that's an ongoing opportunity to look at, is this commercial A primarily in terms of network adequacy? Is this something, more than that we need to look at for both commercial A and B? I believe that's my last slide, and happy to take any questions.
Curious if, the healthcare literacy can help with some of this, because sometimes they just don't know how to maneuver. And so the complaint is an opportunity for us to, okay, I'm seeing
Absolutely.
lots of nodding.
And those conversations do happen, in our outreach to members during nursing investigations or at the direction of the medical director involved in the case, to clarify with the member, not only for that appeal itself, but for ongoing healthcare, a reminder regarding, who is their PCP, what is their network, where should they be looking to access care?
Right. Other questions or comments? Okay, we skipped a couple things, so I'm going to go back to public comment. Are there any public comments on these items?
There are no public comments.
Okay. All right.
Thank you so much.
All righty, we're going to go on to item 6.3, compliance report.
Good afternoon. Can you guys hear me? Is this picking me up? Is this better?
Is the blue light on the microphone?
The green light.
Okay, well,
Does this
hopefully.
work? Okay. All right. Good afternoon. Just a quick report on compliance and some focused topics. I think we did cover a lot of compliance issues earlier. Next slide, please. Fraud, waste, and abuse. So this will be quarter one of 2025. Thank you. Okay. Quarter one, 2025, January, we didn't have any potential cases. February, we had one potential case, and that was submitted to DHCS within 10 days as required and as written in our policies. As of March 13th, we didn't have any potential cases. And then again, as of that date, we had two pending cases with DHCS. So again, those are cases that we've submitted to them, and it's under their review. So we're waiting for their final communication and or closure. And then really quickly, we do have an update to our process going forward. As of March 2nd, we've completed a work order with Cotivity to add additional fraud, waste, and abuse services. So this includes an upgraded platform, which will be a review tool to really help identify billing patterns and, again, prevent fraud, waste, and abuse, before it becomes a much bigger matter. So that's something that's really going to help, again, our compliance program and help solidify our structure and all of our functions as a compliance program. And then additionally, we're also getting special investigative unit, 2 full-time support staff, again, to specifically support the in-depth investigations. Because again, fraud, waste, and abuse is very technical. It's not something that, compliance staff can, just learn with a, set of training. It does require, again, a really specific technical expertise. So again, we will have 2 full-time staff to help support with this. So that's a really positive update, and that we're something that we're all really looking forward to. I'll pause there. Any questions? Next slide, please. And speaking of our compliance work plan, we did revise and make sure to update this work plan to, one, include, all of the federal requirements. And there's a kind of a snapshot here of something that's pulled out of the HHS Office of Inspector General's printout of what a successful compliance program should include. So just highlighting a few things here. We want to make sure there's, effective communication between CCHP and especially our compliance program and Board of Supervisors. So that's something that we are going to ensure, and again, written more clearly into our plan. And again, on the topic of transparency, right? So that's something that we're really honing in on. And again, it's written, so that's something that we're going to follow. And on the same vein, oversight and monitoring, identifying risks, and again, preventing fraud, waste, and abuse. So again, the work plan, I think, is something that we've now put at the forefront because compliance is a very crucial part of what the health plan does. And again, effective communication, more frequent communication, transparency with the Board of Supervisors is something that we will be emphasizing going forward. Questions? Good. Thank you.
Are there any public comments for this item?
There are no public comments.
Thank you.
Thank you.
Okay. We are moving along. We are now at item 7.1. Hello,
Is the mic on?
it
Okay.
is.
Hello, everyone. I'm Bomil Shah. I'm the Chief Information Officer for Contra Costa Health Plan. I've been with the County Health Department for 20 plus years, and I've had the opportunity to work with some of your offices on COVID and familiar faces. I'm going to give you a preview of what's to come today. So the slide deck is pretty short. We've been talking to Dr. Lowe, continuing on our theme of transparency and accountability. We are going to build this executive dashboard internally where we can track the key KPIs for each of our units in the health plan. And the same team that worked on the A3 dashboard and the COVID dashboard is going to help build these dashboards. We are also exploring if we can make some of this data publicly available. So we can, what's appropriate, we can make this available on our websites. So again, building on the theme of transparency. A lot of these building blocks for this data already exist. But again, as Dr. Lowe said, we have been often reactive. So we use that data to react versus proactively using that data. So that's the theme here is we build this executive dashboard. We have KPIs assigned to each unit, and we are proactively working with the quality team on improving. That's the goal here. So again, I'll just show you a preview of what's to come. And some of this was covered in Dr. Barcelo's slides. Can I go to the next slide? This is a trend for the last 2 years. Our membership has been largely flat. We've seen small decreases in our commercial population, about 500 members. We have lost about 200 members, IHSS, and then some churn in the Medi-Cal membership, but it's more or less flat.
And there was a change in the ability to qualify for certain types of healthcare. And so we expected to lose some members, correct?
Quite a few things happened in this 2-year period. We became a single plan model. So we lost some members to Kaiser in this 2-year. But there was also expansion of the UIS population.
Right.
So we gained membership. So net, we have been largely flat.
Okay.
Next slide. So I'm going to quickly go through this. We've seen this in Dr. Barcelo's presentation. This is data tracking over time, appeals. If we go to the next slide. We're starting to break this down by appeal types. So expedited versus regular appeals, and then, what is the appeal about? So all this data will be available on our internal dashboard, and we can share with you as needed. Go to the next slide. And these are the outcomes of the appeal. So again, we can track this on a nightly basis, how we are doing on appeals and the timeliness of the outcomes. Next slide. And this is our grievances data, the same data Dr. Barcelo shared, but again, we want to break this down by the grievance type and then create benchmarks. How do we compare ourselves with the rest of the state? So you can see as of now, for the last 12 months, we have roughly 1.7 grievances per 100,000 members. California Medi-Cal average is 3.1. So we are performing better than the state average for Medi-Cal. And on the right, you can see the types of appeal, right? So there are access, quality of care, quality of service. And next slide. And these are some of the operational type metrics we can develop. So this is tracking the volumes for our advice nurse unit. So the number of calls we get by month and our speed to answer. We're using pretty sophisticated systems in our advice nurse unit, so we can track all kinds of things from first call resolution. Did we have to call back the patient? Track what times of the day, days of the week we get these calls, and do the average speed of answer. Is it variable depending on when you call? So again, we're going to build all this in our executive dashboard and make it available to you all.
I would imagine, Dr. Lowe, you might be able to, or Dr. Levin, or any of you doctors can tell me that's probably the increases because of the amount of flu and illness that was going on at that point, probably.
Yes, correct.
Okay.
But, I think the advice nurse unit is a hidden gem that we need to leverage, and it kind of aligns with what you shared earlier.
Exactly.
Care Letter Council.
Right.
We have such an opportunity to get to members before they even need to show up in the ER.
Right.
If they call our advice nurse unit, they can be triaged, and our physicians are involved. We collaborate with Contra Costa Regional Medical Center and its health centers and its telephone consultation clinic to really get these people seen.
Right.
So we want to do more with this, and we're very excited about it.
Yeah, we need to recognize them for doing that. Thank you.
That's my final slide. Any questions?
Questions? No? Are there any public comments on this item?
No public comments.
No? All righty. Thank you. Looks like we've got our finance report from Brian Buchanan, our interim CFO. Is he joining us online? And I see our compliance person, Mr. Ferrer. I knew it is in the office. I didn't see you, or is in the building. I didn't see you earlier. So welcome. Yes.
Hello, this is Brian Buchanan. I apologize, I'm not there in person. I had some competing issues this morning. But happy to give you an update on where we are from a finance perspective. Could we go
Welcome
to the next slide, please? Okay, what you see here is a summary by service line with our year-to-date actual performance and projected performance for the year. The commercial line, the smaller piece of our health plan, is operating at a small deficit that is fairly consistent with past performance and expected. I would note that expected deficit is inclusive of the 3.7 million of county support that flows to the commercial plan. The on the Medi-Cal plan, we see operating deficits have occurred in the first half of the year, and that's really reflective of inadequate rates. The rates were set actually with the anticipation of 42,000 additional Anthem members joining joining the program, and you know, the rates were just didn't adequately account for the absorption of those members and their usage. So that was recognized by DHCS. Now, rates are set on a calendar year basis. So the rates that came out in January actually reflected a significant increase there of about 15% to our Medi-Cal rates. So that will flip us back to a positive projection for the year for Medi-Cal and a net, you know, small net surplus as we look forward. As we look further forward, you know, I would just call out that the DSNP implementation, the implementation of that program is going to have some significant startup costs and probably will sustain losses for the current estimate. And working with our actuaries is, you know, 3 years likely of sustained losses there. So we'll have to incorporate that into our future planning, and we can talk about that more as we chat about the budget soon. Second, I'd just like to update you on the finance function. Within the health plan. I'm very happy to say that we have added a deputy CFO who will be starting in 2 weeks to lead the health plan finance function. She's joining us from Alameda Alliance, CPA, significant background and experience. So very happy to have her joining. And we have been working very hard to firm up and streamline the processes, the financial reporting processes within the health plan. Bamil has been very, very helpful in pulling together the appropriate data sets that we need to support our regulatory filing. I'm happy to say also that we have emerged from a corrective action plan that was related to not making timely filings. We have been on track with our filings, and we have emerged from that corrective action plan. We are still doing, I would say, a little bit of cleanup with regard to our filings. It is likely that we will refile probably the past 2 quarters with DHCS and DMHC in order to clarify certain items and set up certain allocations within those filings more appropriately. I wouldn't view that as particularly significant. It's not entirely unusual to go through a refiling, but once we complete those, we'll share those with members of the JCC. And I think going forward, I think the better way for us to talk about once we get those filings cleaned up, the better way to talk about our finances will be to actually reference our quarterly regulatory filings. So that's probably what we will go with going forward here. So happy to answer any questions.
So Brian, looking at your crystal ball, no, I'm kidding. We were talking earlier about all of the different scenarios of what ifs. I imagine you're looking at that as well.
Absolutely. Yes.
Okay.
Been having a lot of conversations with, well, certainly with our friends at CAPH, Rich and Erica. Also with the local health plans of California. It's the hot topic of conversation. I think Erica summarized it very well. At this point, you can go crazy trying to model out all of the different things that may happen. We are working on some of the things that seem most likely to happen. I think that, as Erica noted, the GPP program going away and what the impact of that will be. Plus, the impact of, for instance, something like implementing a work requirement that will both reduce our reimbursement and also create additional administrative burden for the organization. So modeling those things out and trying to see where we are is, that's actively on all our minds.
Thank you. And I'm glad that you've got your second in command too. Are there any questions or comments from the rest of the committee? No. Are there any public comments on this item?
There are no public comments.
Thank you, Brian.
Thank you.
We are to the last 7.3. Would it make sense to put 9:30 to 12:30 in the future just because
Right now it's
9:30 is much better for East County for me.
Yes, if that's amenable to the JCC, I'd love to have a 9:30 to 12:30 meeting.
Do that, just so people are aware, and then we'll figure out, I'm assuming we'll be in person, so you may not need to have us coming from our offices unless we end up doing that.
Right. But I just want to create reasonable expectations for people, and that way we plan accordingly.
The big breakfast.
So our next meeting is scheduled for June 6th, 2025. If we are joining virtually from one of our offices, it'll be listed on the agenda. Otherwise, it'll be here. I just want to thank everyone for choosing to do the work that you do. It's not easy. It's been hard after COVID and everything, and then all of the things that we're tackling. I just want to say thank you for doing what you do, and have a wonderful day. And we're adjourned.